First, I want to welcome all of you in our 8th Ain Shams University International Clinical Oncology Conference. It's our 3rd day, and I think all of us are very anxious for this pressed session. First, I want to welcome our chairman, Professor Dr. Hiba Zawahri, Professor of Clinical Oncology, National Cancer Institute, Professor Dr. Medhat Sebai, Professor of Radiation Oncology and the head of the department NCI, my friend, Professor Dr. Abeni Hilal, Professor of Clinical Oncology, National Cancer Institute, and our guest, Professor Lubna Aiz Al-Arab from the Hematology Unit, and my dear colleague in the breast unit, Professor Dr. Muhammad Sabri, Professor of Clinical Oncology, and just came now and arrived, Professor Dr. Hani Abdelaziz, please come. Professor of Clinical Oncology, Ain Shams University. And we will start, please, Professor Hiba.
Afternoon, everybody. It's my great pleasure and honor to share this session of breast cancer, and I would like to congratulate all the staff and faculty in Ain Shams Oncology Center and their success and continuous effort to do such a high caliber scientific meeting is very appreciated from the all oncologists. Thank you very much all the team and the organizer, and many thanks to Dr. Niveen Gadu. She did a lot of effort. Now we have a hot program on the breast cancer that will cover HER2 positive as well as luminal, and then we will go through many aspects of breast cancer practical condition to be solved. We are honored to introduce the first speaker. She is Sarah to Lenery. Sarah is a well-known medical oncology professor. She has a lot of publication and many YouTube educational sessions for breast cancer. She is Dana-Farber University, and she is graduated from Harvard School of Medicine, and she is going after women's cancer, either gynecologically or breast. Her research focused on the development of novel therapy in the area of breast cancer, and she have many chair in clinical trials. So I hope that Dr. Sarah is virtually seeing us and following us, and we are listening to her presentation today. Her title is, the title of Dr. Sarah is Cdk46 inhibitor in breast cancer. What is its position in past, present, and future? So please, Dr. Sarah, Professor Sarah.
Also, Dr. Tamer Refat is with us virtually. Welcome, both of you.
Okay. بيكون شيء لطيف ان الفيرتشوال يسمع.
My name is Sarah Delaney, and I'm a breast medical oncologist at Dana-Farber Cancer Institute. Today I'm going to be discussing Cdk46 inhibitors, the past, the present, and the future. Listed here are my disclosures. As we can see here, over the last several years, we have seen tremendous advancements in the progress for treating our patients with metastatic hormone receptor positive breast cancer. We have seen introduction of targeted therapies in combination with endocrine therapy, initially starting with the introduction of mTOR inhibition back in 2012, And then starting in 2015, we saw the introduction of CDK4/6 inhibitors, and then more recently, the introduction of alpelisib. We know that CDK4/6 inhibitors really work by causing a halt in the cell cycle. CDK4/6 normally causes phosphorylation of the RB protein, which then causes release of E2F, which then causes transcription of key genes that help move the cell cycle from G1 to S. And so if you halt the if you actually inhibit CDK4/6, you will then get halting of the cell cycle at that G1 to S transition point. And so in essence, the cell would go into a senescent state, and then potentially with prolonged senescence, we could see apoptosis. And we have seen introduction of 3 different CDK4/6 inhibitors which have been approved, including palbociclib, abemaciclib, and ribociclib. We have seen that these agents preclinically preferentially seem to inhibit proliferation of the luminal hormone receptor breast cancer cell lines, as you can see here, but interestingly, they also can halt the cell cycle within HER2-positive cells, and there is work ongoing in this space clinically as well. But what we have seen with these 3 different CDK4/6 inhibitors is really remarkably consistent data suggesting that adding a CDK4/6 inhibitor to endocrine therapy in essence doubles progression-free survival. So you can see here within the first-line trials, really consistent hazard ratios around 0.55. And then even in the second-line setting, and while these trials have slightly different trial designs and patient populations, you're still seeing remarkably consistent benefit with regards to progression-free survival, regardless of which CDK4/6 inhibitor is utilized. But what is remarkably interesting is that we are now also seeing overall survival benefit. And so we'll discuss this, but both in the first line and in the second line setting. I think one thing that people often mistakenly think is that endocrine therapy and CDK4/6 inhibitors are not going to cause robust response rates, even though they cause very prolonged disease control. But in truth, what we see with CDK4/6 inhibitors is a very high response rate, both in the first line and in the second line setting, with first line response reaching almost as high as 60%. And so I think this is important to keep in mind, for example, when you're seeing a patient who may have extensive visceral disease, that these agents actually do cause objective responses, and that these responses are not super delayed, that these responses still can happen within the first several months of therapy. So here you see the Kaplan-Meier curves for progression-free survival, again with palbociclib, ribociclib, and abemaciclib, and again, remarkably consistent hazard ratios here of around 0.55. But what I think is really very exciting as we were eagerly awaiting these data is that not only is it doubling the PFS, but in fact it is also significantly improving overall survival. And these data we just recently saw at ESMO from Monalisa 2, which was the first-line trial of letrozole with or without ribociclib. And here you are seeing an improvement in OS from about 51 to 64 months, consistent with a hazard ratio of 0.76. And we can see that these agents have really changed the landscape for hormone receptor positive breast cancer and have had significant improvements in outcomes for our patients, where we're seeing that by year 6, about 44% of patients are still alive. So really, again, we have changed how long patients with metastatic hormone receptor breast cancer can live. And so I think really important to realize that this has changed the trajectory for these patients. And importantly, these benefits were seen across the subgroups. One interesting subgroup analysis that I think is hard to know what to make of is that there did seem to be less advantage for use of ribociclib in terms of overall survival in patients without de novo metastases, whereas the de novo patients had a hazard ratio for OS of about 0.52, you see the non-de novo patients have a hazard ratio of 0.91. Why this is, I'll say it's hard to know. And I think, again, this is a small subset of the overall population, and so I do not think at this point in time we can say that patients who have recurrent disease will not have survival benefit from CDK4/6 in the first-line setting. And so I think it really should be a standard regardless of presentation clinically, because again, I don't think we can draw definitive conclusions from this subset. We're also seeing survival benefit in the first-line setting in our premenopausal patients, and these data come from Monalisa 7, which is really our only pivotal study that focused on the premenopausal population. It took women who had had less than or equal to 1 prior line of chemotherapy in the advanced disease setting with no prior chemo for their metastatic disease, and all of them got ovarian suppression with either tamoxifen or an aromatase inhibitor, and they got randomized to receive that with or without ribociclib. And what we saw was a doubling in progression-free survival, but also, importantly, an improvement in overall survival going from about 48 to 58 months. And I think this is important to realize because there is some crossover that is seen both within Monalisa 7 and also within Monalisa 2. Here in this particular trial, you can see about 25% of patients in the placebo arm ended up going on to get a CDK4/6 inhibitor. And despite this crossover, we are still seeing OS benefit. So again, regardless of whether or not someone is premenopausal or postmenopausal in the first-line setting, I really think CDK4/6 inhibition should be our first-line standard. One caveat I would keep in mind, however, is that you cannot use ribociclib in combination with tamoxifen, and we did see that there was more prolongation of the QTc when tamoxifen was combined with ribociclib. And so in a premenopausal patient in the first line, you would want to consider ovarian suppression with an aromatase inhibitor and ribociclib. But that being said, we are seeing also data for benefit of CDK4/6 inhibition even in later lines. So this is in the second line and beyond. So Monalisa 3 had a unique design because it was using fulvestrant with or without ribociclib, but included patients both in the first line and in the second line setting. Monarch 2 is a pure trial that was really just post-AI therapy. And so this was, again, just 1 prior line of endocrine treatment. Whereas Paloma 3 was very different. It allowed any number of lines of endocrine therapy and up to 1 line of chemotherapy. But again, despite this, you see the hazard ratios are really pretty much the same. So, I think that is showing that you do see benefit regardless of the prior exposure of treatment. But you do see that the median PFS does go down as people have had prior pretreatment, as you would expect. So when we looked at the data from Monarch 2, which again was the fulvestrant with or without abemaciclib trial, we again saw that consistent PFS difference, and we also saw overall survival difference with a delta of about 9 months. But what I think is interesting there are some differences that are emerging in the subgroup analyses from the different CDK4/6 inhibitor trials. And so this study with abemaciclib shows really greater improvement in terms of survival with patients who have primary endocrine resistance compared to secondary endocrine resistance. Now keep this in mind because this is different than what we're seeing in Paloma 3, which was, again, the pre-treated trial of fulvestrant with or without palbo. And while the initial overall survival analysis did not suggest survival benefit, there was an updated analysis. This is an exploratory, unpre-planned analysis, but did show that there was a benefit in terms of overall survival, but this benefit was really restricted to those patients who had not seen prior chemotherapy, and that the benefits were far greater in people who had endocrine-sensitive disease compared to endocrine-insensitive disease. So this is different, again, than in Monarch 2, where we're seeing that the primary endocrine refractory patients are getting greater survival benefit, whereas in Paloma 3, we're seeing it's the patients who have more endocrine-sensitive disease that are getting better benefit. But again, you can't really make cross-trial comparisons. These are very different patient populations, but does make one wonder if there are some differences between these agents that may be coming out in these subgroups. Monalisa 3, on the other hand, again, remember, looked at both first-line and second-line patients, did show an overall survival benefit across the intent-to-treat population, and also within the first-line patients who had gotten fulvestrant. But their benefit was really seen both in endocrine sensitive and insensitive patients. And so again, you're seeing some differences here between the different agents in terms of survival benefit across subgroups. So here, again, the standard would be to use CDK4/6 inhibitors in the first line, but I think many question, could you just delay utilization to the second line, because we're also seeing survival benefit here. And so there are trials that are ongoing trying to look at the sequencing question about whether or not it matters if you give the CDK4/6 inhibitor first or second, and if that would impact overall survival. There's one study called the SONIAS trial that is exploring this. But we don't have these data at this point, and given that we generally like to use our most effective therapies up front, personally I think we should be using CDK4/6 inhibitors in the upfront setting. And when you do so, again, you can use it also in premenopausal patients or postmenopausal patients, because you are seeing benefit in the subgroups of trials that looked at the premenopausal subgroups in Paloma 3 and Monarch 2. And again, we saw the data in Monalisa 7 for all premenopausal patients. I think the challenge, however, is that we haven't been able to tease out clinically what subgroups of patients seem to derive benefit most from CDK4/6 inhibition, and if there are patients who don't derive benefit. Because here you look across all these different clinical subgroups, and in fact, all of them are benefiting. We also have tried to look at various biomarkers to see, can we select out those patients who are most likely to benefit or those patients who are not going to benefit. And again, you see all biomarker subgroups here are deriving benefit. There was a very interesting analysis that was performed and presented at San Antonio in 2020, looking across the Monalisa trials and looking at intrinsic subtype. Again, trying to tease out, is there a particular group of patients getting the most benefit, and are there some patients that are going to be refractory? And you can see, to my surprise, the group of patients that derived the greatest benefit were those patients who had a HER2-enriched intrinsic subtype, where you see a hazard ratio of about 0.39 in terms of PFS, whereas on the flip side, you see no benefit in the basal-like patients. I will say that clinically we are not yet utilizing intrinsic subtype, and so we wouldn't know this level of data to help us select out patients most likely to benefit or not benefit. And again, the basal-like subgroup is a very tiny subset of the patients that we treat, and so it's hard to know what to do with this. But given these interesting findings, there is a planned prospective study that would have basal-like patients go into upfront chemotherapy rather than CDK4/6 inhibition in the first-line setting, and then try to tease out if it really is these HER2-enriched patients that are getting the most benefit from ribociclib, and if this is different, for example, than you would experience with a different CDK4/6 inhibitor, really asking the question, is this unique to ribociclib that the HER2-enriched patients are deriving the greatest benefit? So I think more to come with utilization of intrinsic subtype, but not quite ready for prime time in the clinic right now. And so while we've said that we should all be using CDK4/6 inhibitors standardly in the first line, one question that then arises is, well, is there a best endocrine backbone to use when you're giving these CDK4/6 inhibitors? Meaning, does it matter if you choose an aromatase inhibitor or fulvestrant? Would one be better than the other to use as the partner with endocrine treatment and CDK4/6 inhibition? And so this trial, the Parsifal study, looked to address this question really with the hypothesis that maybe fulvestrant would be better than an AI, because we have data from other randomized trials, such as the Falcon study, which had suggested that fulvestrant in the first-line setting was better than an aromatase inhibitor, particularly in those patients without visceral involvement. So this trial took patients with endocrine-sensitive disease in the first-line setting and randomized them to get fulvestrant to palbociclib or letrozole palbociclib. And in fact, what you see is there is no difference, that the PFS is really very similar. So fulvestrant palbociclib is not superior to an AI palbociclib, but it also was not non-inferior. So, really, I think these data suggest that at this time, there's no best optimal endocrine partner to choose with your CDK4/6 inhibitor, that clinically we should be making these decisions based on prior exposure. So for example, if a patient recurs on an AI or within a year of an AI, you want to use fulvestrant, whereas if someone's endocrine therapy naive or had their AI years ago, then you could use an AI. And so really it doesn't change the way we would normally make our selection for our endocrine backbone. And so if all our patients are going to be getting either an AI and fulvestrant with CDK4/6 in the first line setting, what happens when they progress? And what do we do then? I think many have wondered, should we be continuing the CDK4/6 inhibitor beyond progression, just swapping out the endocrine backbone, kind of like what we do with HER2-positive disease when people have had multiple lines of therapy. We will sort of swap out the chemo and continue the trastuzumab. And so the question is, does continuation of CDK4/6 inhibition beyond progression still have benefit? And the truth is we don't know the answer to this. While I think many people clinically are doing this without robust data, personally I think that's not ready for prime time. There are different types of resistance mechanisms that occur with CDK4/6 inhibitors, some of which may lead to lack of benefit with continuation, such as RB mutation. So I think we need data here, and there are trials that are still ongoing, one being MAINTAIN, looking at the use of ribociclib beyond progression, and then the other being PACE, looking at palbociclib beyond progression. And these trials have yet to report. We're hoping to see some data from these in 2022, but we do not have these data at this time. So another question is, well, again, we keep saying that we should be using endocrine therapy and CDK4/6 inhibitors, but how do we know how that compares to chemotherapy? And so if we see a patient, for example, with pretty extensive visceral disease, how do we choose between endocrine therapy and CDK4/6 or chemo? And so there have been a couple trials that have now been done to address this question. One was Young Pearl, which was a randomized phase 2 specifically for premenopausal patients, and it randomized them to get ovarian suppression with an AI and palbociclib and compared it to capecitabine. And here in this randomized phase 2 study, you do see that the CDK4/6 inhibitor actually did better than capecitabine with regards to progression-free survival, with a delta of about 5.5 months. So to me, this suggested that using CDK4/6 inhibitors up front was, maybe better than chemotherapy and would be really supporting our use of these agents first line. However, again, this was a randomized phase 2 and specific to premenopausal patients. And so what about in postmenopausal patients in a larger trial? And so the Pearl trial did examine this, comparing either exemestane palbociclib or fulvestrant palbociclib to capecitabine. And here you see that there was no difference, that the endocrine therapy and CDK4/6 inhibition was similar to capecitabine in terms of progression-free survival, and actually also in terms of overall survival, again, really supporting that we should be using CDK4/6 inhibitors because they are associated with better quality of life relative to chemotherapy. We do also have to keep in mind that we have 3 different agents, and they do have different toxicities, and we do have to monitor appropriately for this. And so we do know that abemaciclib, for example, is associated with some GI toxicity, whereas both ribociclib and palbociclib are associated with neutropenia. There are some unusual toxicities that can occur, such as thromboembolic events, which have been seen with abemaciclib, and a risk of interstitial lung disease, which has been seen with all 3 agents, although be it rarely. And so we do have to put in place monitoring for neutropenia, make sure we're appropriately monitoring for GI toxicity, particularly with abemaciclib, and that in those patients getting ribociclib, there can be prolongation of QTc, and so you do need to do EKG monitoring. And so here is just a generalized schema for how to approach our metastatic patients where we want to give endocrine therapy and CDK4/6 inhibition up front. Upon progression, then we have choices of whether or not we want to give endocrine therapy with targeted agents. So if they have a PI3 kinase mutation, I'm often using alpelisib, whereas if they lack a mutation, I'll often consider integrating mTOR inhibition at that point in time. But I think this space will change over the years to come, where we are seeing studies looking at oral SERDs in combination with CDK4/6 up front, or using oral SERDs in the late line setting. And so these upfront treatments, again, I think will evolve over time. But I think our standard should remain CDK4/6 inhibition with endocrine therapy in the upfront setting. And we do not yet have a biomarker predictor for understanding who's going to benefit versus who's not going to. And so really, again, it should be for the vast majority of our patients. And so while currently that is our standard, where are we then headed? So I think one place we're headed is trying to move these agents into earlier lines of therapy. We know, for example, that patients who have high-risk hormone receptor positive breast cancer are at more than just an insignificant risk of recurrence in the early stage setting. And so there have been several adjuvant trials that have been designed really trying to target these patients to prevent recurrence. The first of these studies that reported was the PALACE trial, which took patients with stage 2-3 breast cancer and randomized them to get endocrine therapy with palbociclib or just to get endocrine therapy alone. This trial did allow some stage 2A patients on, so up to 1,000 patients, which ended up being around 20% of the population, whereas the rest of the patients, about 60% of patients, had what we would consider high-risk disease, so having 4 or more nodes involved, or if they had 1 to 3 positive nodes, they had to have a large tumor or be high grade. But I think we're all very surprised and disappointed to find that adding palbociclib to endocrine therapy in early stage disease did not improve disease-free survival or distant relapse-free survival. And even when you looked at the high-risk subgroup of patients, you really still see no benefit. So some were wondering if it was because in this particular trial there were very stringent criteria for discontinuation of drug for toxicity, particularly with the neutropenia, and there was a high discontinuation rate with about 45% of patients discontinuing the palbociclib prior to the 2-year mark. And so many wondered if that could be influencing the outcomes that we saw here. But in fact, there was an analysis looking at exposure to treatment with outcome, and it did not seem that it impacted the disease-free survival in this trial. We also saw a study looking at a different patient population, which were patients who had high-risk disease after preoperative therapy. This was Penelope B, where they took these high-risk patients defined as patients who had a CPS-EG score of 3 or greater, or 2 if they had pathologic node-positive disease at time of surgery. They then got 1 year of palbociclib with their endocrine therapy or placebo. And this study did not find benefit for palbociclib in the adjuvant setting. But one intriguing thing is that when you look at their disease-free survival curves, you do see early separation of the curves, where at the 2 to 3 year time frame you're seeing benefit for palbociclib, but by the time you get to year 4, you really see that that benefit has gone away. And so I think keep that in mind as we look at further data, but I think also have some caveats in your mind because there were very few events at those early time points in this trial and that would not have met, for example, statistical significance at that 2 to 3 year mark. So then we saw data with abemaciclib in monarchE, and this trial was specifically for very high-risk patients, so 4 or more positive nodes, or 1 to 3 positive nodes with either a tumor over 5 centimeters, high grade, or high Ki-67. Patients got 2 years of abemaciclib with their endocrine therapy or adjuvant endocrine therapy alone. And we did see that, again, this trial really did randomize those very high-risk patients, with 60% of patients having 4 or more positive nodes. And we've now seen data with 19 months of follow-up at the time of their primary outcome data, and it did suggest about a 30% reduction in invasive disease-free survival events, with a 3% difference between the 2 arms. So this study was a positive trial as opposed to the 2 previous palbociclib trials that we've seen, and we see that there was benefit across all of the subgroups. So importantly, there was not a subgroup that did not seem to benefit. And what I think is important in my mind is that the events that abemaciclib is preventing are distant events. So this was predominantly liver and bone metastases, which I think are events that are likely in the future going to lead to survival differences. But again, that would take many years to see, but I think really meaningful differences in outcomes for our patients. So I think this left many of us confused. Why are we seeing such different outcomes between all these trials? And I think it's hard to know. Obviously, these trials were designed with different patient populations, which certainly could be impacting it. Though some would argue Penelope B also had a very high-risk population, although defined differently than monarchE. Could it be drug exposure, where we see that, for example, Penelope B only used a year of Palbo, whereas a Monarchy and Pallas used 2 years? And could it also be the high rates of discontinuation from Pallas? And what about differences between these agents? Is it differences in potency of CDK4/6 inhibition, where maybe abema is more potent than Palbo? There is another study looking at 3 years of adjuvant ribociclib with the Natalie study, and these data have not yet reported. This trial just completed accrual in 2021, so we'll have to wait probably another year or two for data. But again, that would help us better understand if it's the agent, the design, or the duration. So I think the main question now is, should we be prescribing CDK4/6 inhibition? I think those who argue yes will say that it does have almost 25-30% risk reduction, that these patients have high-risk disease, do tend to relapse early, that it's not leading to endocrine therapy discontinuation for the most part, so it's unlikely to have bad impact on their treatment. And the risk of serious toxicity, such as ILD or DVT, are really low, as seen in the Monarchy study. There are others that argue, though, that this is early data. So initially we saw data with 15 months of follow-up. Now we've seen data with 19 months. And I think some would like to see data after people have finished their 2 years of abemaciclib. And so I think we'll have to wait for that to emerge, but hopefully that will be available in the near term. Some have also argued maybe you're just delaying metastatic disease presentation. You're not really curing patients. And again, longer follow-up would help actually address that question. Some are worried about these rare toxicities like ILD and DVT. And so there are those who argue they want longer follow-up before they're going to adopt utilization. So I think, where are we headed? We certainly know that these agents are standard in the first-line setting, that there is data to suggest that abemaciclib in particular can also help in the adjuvant setting. I think this likely will become a new standard of care for our early-stage, high-risk ER-positive patients. But I think we do need to understand several things. Really right now abemaciclib is only utilized in the first 2 years. There's certainly some thought about whether or not we should be integrating this agent for longer than 2 years. Should we be utilizing these agents in people who never got them in the later line setting? Now we're giving the endocrine treatment for 5 to 10 years. Should they get abema in that late exposure setting to prevent late recurrence? And what about potentially even substituting CDK4/6 endocrine therapy for some of our patients who get chemotherapy? So for example, those high anatomic risk, low genomic risk patients where you don't really see much benefit from chemo, but they have, high anatomic risk disease, should they just get endocrine therapy and CDK4/6 inhibition? And in truth, we don't know that, because in Monarchy, 95% of patients had received chemotherapy. I also would love to understand if there's going to be benefit from continuation of CDK4/6 inhibition beyond progression. And then I think we need to see novel strategies being taken with other combinations. And so there are registration studies ongoing with oral SERDs, also with novel PI3 kinase inhibitors, AKT inhibitors. And then I think there will also be a movement into the HER2 positive space, where we are now seeing ongoing studies, and including a registration study with the Patina study in the metastatic setting, and eMonarch-HER in the adjuvant setting for ER-positive, HER2-positive disease. So I think a lot more to come with CDK4/6 inhibition, but really these agents have made tremendous impact on outcomes for our patients, now with patients living well beyond a median of 5 years in the metastatic setting. I think very much attributable to the impact these agents have had. Thank you so much.
Hi. Okay, Professor Sarah, thank you very much for very updated presentation and putting some landmark for practice for luminal group of patients or HER2 positive disease. Maybe everybody have some question, but I can argue with you some important point. Being now we are thinking of adjuvant, and some people saying yes or no, and I know that in the last St. Gallen the majority, more than 70% who's telling as if you are just mentioned, it's too early. Abemaciclib in adjuvant, the same question have been discussed. It's a little bit early, and in between the question or in between lines, it may be for some high-risk patient, and they suggest that it may be for patients who develop another breast cancer many years later on and they exhaust or hormonal line of treatment. But my question to you, are we encouraging enough to use Cdk46 inhibitor in the neoadjuvant luminal group of patients instead of chemotherapy? Because now they are showing some international study that as long as we are confident to do it in first line and it is standard, and then by thinking putting in the adjuvant, why not while the tumor is very naive and can respond? Can you comment on this neoadjuvant usage?
Yeah, no, that's an excellent question. I think one that we actually do get in clinic not infrequently now. So I think one question is also the answer to that also stems from whether or not we think Cdk46 inhibitors are ready for prime time in early disease cancers in general. I think as you pointed out, some people are concerned about the monarchy data because there was a median of 19 months of follow-up at the time of the primary outcome data. But we actually will now be seeing longer follow-up data in a couple weeks at the ESMO virtual plenary, which was just posted, I think, online earlier this week. And so we will see that longer follow-up data. And so and at that point, the majority of people will be off their adjuvant abemaciclib, which I think was the concern people have had is, what happens when you stop those 2 years of abema? Are those curves going to come back together? And so I think we need to see those data, but I think if they continue to show a similar or better 30% reduction in IDFS events, that would confirm my use of abemaciclib in my high-risk patients. So only those patients who met monarchy criteria. But then that circles back to your question, which I think is even more complex, is in the neoadjuvant setting. Because my decision-making in the neoadjuvant setting, I think it's challenging because I want to know, is this a patient, first of all, who needs chemo or not? And so how do I determine that? And one, I usually want to get a genomic assay. And so what we've started doing in our practice is we've started getting genomic assays off the core biopsy. And so if I find that the core biopsy has an oncotype that's on the lower end of things, so certainly under 25, that's a patient where I know they're not going to benefit from chemo. And then if I'm going to give them pre-op endocrine therapy because they have locally advanced disease, then I have considered adding Cdk46 inhibition to that, knowing that it would have been something I would have done in the adjuvant setting anyway if they had, met enough clinical anatomic risk for monarchy. But I think it's complex because we don't know in those people with a little less disease than monarchy would Cdk46 inhibition work without chemo. And actually there are efforts in the cooperative group system in the US at designing trials to specifically address this very question because I think it is very critical, but the truth is we don't have a clear answer to it.
Yes. Dr. Sarah,
Sarah, thank you for your comprehensive
Dr.
talk.
Lobna, I have one question for Dr. Sarah. I want to thank you for your elegant presentation. And by the way, I'm following your all teaching sessions on Dana-Farber Institute on Vomedib application. It's a very useful application for me. I want to ask you about the delay, explanation of the delay of release of overall survival benefit and PFS for Monalisa 2 comparing to Monalisa 3, because both studies are treated patients in a first-line treatment either with ribociclib plus AI or ribociclib plus fulvestrant. We see a lot of delay of release of overall survival benefit from Monalisa 2 comparing Monalisa 3 trials, which had 2 upgrades in overall survival over the last 2 years. Can you explain the delay of release of Monalisa 2 trials, survival benefit and PFS benefit? Because post trials
take longer to see the overall survival benefit from Monalisa 2, even though that study started earlier compared to, for example, Monalisa 3. Is that what you're asking, or are you talking about the delay in not seeing data, which I think many of us are also curious about? Why have we not seen overall survival data from Paloma 2, which started the earliest with palbociclib? And I think that has been a major question. So, I think just in general, regarding the Monalisa studies, certainly a first-line study is going to take a lot longer to read out because these patients are living so long and that you have to wait for events to be able to meet your event rate that was pre-planned in your statistical analysis to look at OS. And so every trial was designed a little differently in how they wanted to at the timing to look at that OS endpoint. But again, because it's a first-line study, my guess is that to have a median that's over 5 years just takes a really long time to meet events to report. Whereas Monalisa 3, the ITT population was a combination of both first and second-line patients, and so the median OS is going to be shorter, and events are going to happen earlier, and so you're going to be able to report a bit earlier than a first-line study. But I think, to your point, it does bring up all these questions about the timing of which we're seeing data come out, because I've often wondered, well, is there going to be survival benefit with the other CDK4/6 inhibitors? Why, for example, have we not seen survival benefit with palbo in the first-line setting yet, when that study started the earliest? And I think we don't know. It may be that there is a difference in statistical plan for when the events were going to be looked at. But I think it brings up a lot of questions because we still don't really understand the differences between these agents. And I think cross-trial comparisons are dangerous, but I think we do need to understand if these agents are different, and I certainly don't know.
Okay, Dr. Sir, I have another question. Do you think that era of upfrontly testing PIK3 mutations, it will change the position of fulvestrant plus ribociclib for hormonal sensitive or de novo patients as a combination?
It's an excellent question. I think in the first-line setting, my preference is to use a CDK4/6 inhibitor, even in a PIK3CA mutant patient, because we know there's survival benefit from CDK4/6, whereas we don't have OS benefit technically with alpelisib. And so while I do typically get genomic testing, I'm using it in essence to make my first-line treatment decision. I only use it upon progression of the CDK4/6 inhibitor, and then if they have a PI3 kinase mutation, then I would use endocrine therapy and alpelisib in that second-line setting. In truth, I will be honest, I often get retesting of genomics after progression on CDK4/6 nowadays. In the US, we have access to getting ctDNA assays, which makes it kind of easy. And I'm always curious to know, do they have an ESR1 mutation? And should that influence my utilization, for example, for subsequent aromatase inhibition or not? And so, I have been getting that data, but usually PIK3CA mutations are not generally acquired. They're usually, you're going to find most of them up front. And so, there are very few that are acquired post CDK4/6. So in truth, if you got that information up front, you technically don't really need to retest.
Professor Sarah, thank you for your comprehensive talk. My question related to leptomeningeal seeding or leptomeningeal metastasis. Do you have any experience with the role of CDK4/6 inhibitor? Those patients specifically doing very bad with chemotherapy.
I know leptomeningeal disease is such a tough disease, and certainly it's not common in ER-positive disease, probably on the order of 5 to 8% over someone's lifetime with metastatic ER-positive disease. We do occasionally see leptomeningeal disease, sometimes even more commonly in those lobular cancers where there's seeding of the lining. We actually had done a study looking at abemaciclib in patients with parenchymal brain metastases, but we also had a cohort of patients with leptomeningeal disease. And, it's tough because I think you have to look at what's the correct endpoint in a trial looking at patients with leptomeningeal disease. This study was trying to look at response by MRI criteria. And we did see, in a very small group, I think it was like 8 patients, there was 1 technical CR. But what was, to me, more interesting was the fact that these patients, their overall survival was somewhere in the range, I think, of 8 or 9 months, which is, I think, much longer than we would typically expect for a patient with leptomeningeal disease. And so it seemed provocative. Again, I think very tiny numbers, hard to know what to make of, but, it did make you wonder if we were seeing activity. And this was, again, the abemaciclib monotherapy trial.
Professor Sarah, thank you for your presentation. In clinical practice, if you are faced with a postmenopausal patient with high primary hormonal resistance, how can you choose in between the 3 CDK4/6 inhibitors in your clinical practice?
Sorry, you said a premenopausal patient or post?
Yes, yes,
I missed that.
yes. It's postmenopausal patient.
Post. Yeah, it is tough. You know, in the first line setting, you know, technically right now the only agent we have overall survival benefit for is with ribociclib. But that being said, you know, that subgroup is sort of interesting that the majority of the benefits in the de novo patients. I'll be honest, so I haven't, well, one could argue you should use ribociclib because it is the only trial with survival benefit. I haven't sort of uniformly switched over to only using ribociclib in the first line patients. You know, I think it's, one, we haven't seen the survival data from the other trials. It's not that they haven't met OS, we just haven't seen it yet. And two, I think the data has been so consistent across the drugs in general that I haven't felt compelled to pick one over the other. And so usually what I have been doing is, you know, mostly based on some clinical characteristics of the patient. So, you know, I had a patient actually a couple months ago who had baseline very low blood counts. She had a lot of bone metastases, and I chose to use abemaciclib because I was concerned about rates of neutropenia in that patient. Whereas if you have someone who's got, you know, baseline GI issues, you do not want to be choosing abemaciclib for that patient. Or someone who has cardiac issues, you don't want to be using ribociclib. And so I think you can make some judgment calls. But I think most people in practice kind of got used to whatever drug they generally prescribe, and it usually, you know, just go with it. And in truth, it's not really so data-driven. It's just based on what you're used to monitoring.
Okay, thank you very, very, very much. And now we have to move to the second speaker, and we hope to see you next time. Professor Medhat.
Good afternoon, everyone. I would like to thank first the organizing committee, and special thanks to my dear friend, Professor Naveen, for this generous invitation. My second speaker will be Professor William Gredshar. He is the chief as well as the professor of the breast oncology and the professor of medicine and of hematology and medical oncology department of medicine of the Feinberg School of Medicine, Northwestern University. Also is the chief of the NCCN breast cancer guidelines panel and the NCCN breast cancer prevention panel. He is the consultant to the Oncology Drug Advisory Committee of the FDA and the chair of the breast cancer working group. The second session would be on the advances of the HER2-directed therapy. Please, Professor William.
As I prepared this talk, there were new developments even from just a couple of weeks ago at the European meetings that will probably change how we approach patients with advanced disease. And we'll get into that as I put these different drugs into perspective. So what we're going to do is first take a look at the distribution of breast cancer subtypes. And as you know, HER2-positive breast cancer accounts for about 15% of all breast cancers. We have a number of different treatment strategies that are available with a number of FDA-approved drugs that are listed here. They can be categorized into tyrosine kinase inhibitors, oral compounds, lapatinib, neratinib, and tucatinib, antibodies such as pertuzumab, trastuzumab, and most recently margetuximab, and then antibody drug conjugates, including TDM1 as well as trastuzumab deruxtecan. Several of these drugs are new, and we'll be talking about how they fit in as we think about treating patients with advanced disease. The reason that there's a need for continued development of new drugs is shown on this slide. If you look at the top panel and take into account some of the pivotal trials that demonstrated that utilizing trastuzumab markedly reduced the risk of recurrence in patients with early stage disease. In pink, you can see that the early follow-up showed a rather dramatic improvement in outcome. With longer follow-up, we see that the number of patients who are still recurring with metastatic disease is about 25% of patients. So with longer follow-up, these patients with early stage disease are still recurring, and the biggest reason from the pivotal trials that patients died is because of metastatic breast cancer. And one of the strategies that was thought to be a potential solution to this problem was integrating dual targeting, not only in the early stage setting, but as well as in the advanced disease setting. If you take into account the guidelines and how they guide us in terms of taking care of patients, in the first line setting, and we'll talk about each of these areas momentarily, but we have the Cleopatra-like regimen, which is generally thought of as the best first-line therapy with level 1 evidence, and until 2 weeks ago, TDM1 would have been viewed as the appropriate treatment for most patients in the second-line setting. And these guidelines were just put up online in August of 2021, so we'll obviously be updating them with some of the data I share with you. And beyond second line, we have a variety of different treatment approaches, including trastuzumab deruxtecan and tucatinib, as well as combinations of trastuzumab with other chemotherapy drugs, and we'll be talking about that. This is the Cleopatra data, now updated with very long follow-up, all the way out to 99 months. And as you can see, those patients with metastatic disease who received a taxane plus dual targeting with trastuzumab and pertuzumab had a much better overall survival than patients simply getting trastuzumab and chemotherapy. And that improvement in median overall survival was not only sustained, but is clinically meaningful at an improvement of about 17 months with very long follow-up. When trastuzumab first came out, the next drug that was developed was actually lapatinib. And lapatinib was the go-to drug for many years, an oral TKI. And then TDM1, an antibody drug conjugate, was developed. And as you know, the antibody drug conjugate is composed of the antibody trastuzumab, a stable linker, and then a cytotoxic payload, which in this case is maytansine. And the development of TDM1 and its ultimate position as the next line of therapy was based on the Amelia trial, which is shown here. And this was a comparison of lapatinib, capecitabine, which back in the day was the next line of therapy after trastuzumab, or TDM1. And as you can see again with long follow-up, that the median overall survival as well as progression-free survival clearly favored TDM1. And as a result of this randomized data, TDM1 became the second-line therapy following a Cleopatra-like regimen. Now, more recently, there has been the development of other antibody drug conjugates, not only in breast cancer, but other arenas as well. But the newest one that we have in breast cancer is trastuzumab deruxtecan. And if you compare it to TDM1, you can see that there are some distinctions. Number one, the cytotoxic payload is different. It's a topoisomerase 1 inhibitor. The drug to antibody ratio is much greater with trastuzumab deruxtecan, so there's more chemotherapy getting to the target. It does have a cleavable linker, and there is also this concept of a bystander effect, that once the drug is inside the cell, it can also diffuse out, and if there are other cells in the nearby vicinity that may not be expressing HER2 as strongly because tumors are heterogeneous, you can get a bystander anti-tumor effect from the cytotoxic payload. Now, everybody has heard about the Destiny trial, which is shown here. This was a phase 2 trial that involved patients with metastatic disease who had received prior TDM1. The composition of the trial was about half of the patients were hormone receptor positive. Most patients had visceral disease, and these were heavily treated patients, 6 prior lines of therapy as a median. So if you look at the data from this trial, although there was a dose-finding element to the trial, the primary goal was to determine the activity of this drug with a primary endpoint of objective response rate and then secondary endpoints of PFS, clinical benefit rate, et cetera. And this was a quite astounding trial, as you all know, because it demonstrated very clearly that there was a marked response rate. If you look at this population of patients who had significant prior therapy, the response rate was 60%, including a small number who had complete responses, and furthermore, the duration of response was quite good. The one finding from this that caused some alarm, of course, is that patients, at least some, develop interstitial lung disease or pneumonitis, and there were a few patients that actually died as a result of this side effect. So there was a black box warning applied to the approval of this drug, that you should be thinking about ILD pneumonitis, investigate any respiratory symptoms, and also some maneuvers that you can do to mitigate those side effects, including withholding the drug or dose reducing or adding steroids, and depending on the grade of pulmonary problems, symptoms, you may actually have to discontinue the drug. Now, what has been found with longer follow-up of this initial trial is shown on this slide. This presented at San Antonio last year. The response rate is sustained. The median duration of response actually increased. The PFS actually increased. And importantly, the fraction of patients who actually developed any level of pneumonitis was about 15%. And there was no increase in the number of patients who actually had very severe pneumonitis, ultimately dying of it. So it appears to be recognized by clinicians and managed effectively. Now, we also know that in the Destiny-1 trial, there were some patients who did have CNS disease. There were a small population of patients, 24 of the 168 patients who had CNS disease, 20% of whom were CNS treatment naive. The patients did get a variety of different therapies, most frequently radiation therapy, or in a smaller fraction, radiation and surgical excision of the lesion. What was demonstrated looking at this small population is that the PFS for the patients with brain mets was actually as good, or maybe numerically somewhat better, compared to the overall cohort. And again, the objective response rates were quite similar. So again, it suggests that there is activity of this drug in the CNS, although clearly we need more data. Now, the big news from ESMO last week, just 1 week ago, was reporting of the Destiny-3 trial. And this was a comparison of trastuzumab deruxtecan to TDM1 in patients with HER2-positive metastatic disease. The prior treatment in these patients is very succinctly summarized. Just about 100% of patients had prior trastuzumab, 60% pertuzumab. There were about 8% who had de novo metastatic breast cancer, the vast majority having been treated previously for metastatic disease. And in this group of patients in this randomized trial, there were a fraction of patients, about 20%, who did have brain metastases. But in other ways, it was a very typical metastatic breast cancer patient population. And these are the results presented by Javier Cortez. Again, these were patients who had previously been treated with trastuzumab and a taxane in the advanced disease setting, and they could have had clinically stable brain metastases, as I already mentioned. If you look at first the PFS, there's a rather dramatic separation of the curves that occurs very early, and the 12-month PFS rate is 75% for the patients with receiving T-DXd versus 34% for those receiving TDM1. And if you look at the objective response rate, again, a dramatic difference favoring patients who receive trastuzumab deruxtecan compared to TDM1. The vast majority of patients responding, an overall response rate of just about 80% versus 34%, and also a 12-month overall survival rate that favors trastuzumab deruxtecan. If you look at the side effects that have been reported to date, again, it seems that we're getting better at identifying patients and mitigating the possibility of pulmonary symptoms, with relatively few patients having any sort of severe pulmonary findings or pneumonitis, no patients dying, and similarly, no significant cardiac toxicity was identified. So if I were betting, I would guess that in all likelihood, trastuzumab deruxtecan may move up in the algorithm for treating patients with the HER2-positive metastatic disease, possibly displacing TDM1. And within the realm of antibody-drug conjugates, the other one that is very close perhaps to approval, or at least will be submitted to the FDA, is trastuzumab duocarmazine, or SYD985. Also an antibody-drug conjugate, the payload different than TDM1, And data was presented at ESMO this year from the so-called TULIP trial that looked at patients with HER2-positive unresectable advanced disease who had gotten at least 2 HER2-targeted regimens, or they could have just received TDM1. And again, this was a randomization between trastuzumab duocarmazine or treatment of physician's choice, which could have been a lapatinib-cape regimen or trastuzumab-cape or other trastuzumab chemotherapy regimens. And what the data demonstrated, as presented by Dr. Sora from Spain, is that the PFS was significantly improved with trastuzumab duocarmazine, an improvement of about 2 months, as well as at least a numerical suggestion, although not statistically significant, that overall survival is improved. There was only a modest difference in the overall response rate between the 2 groups, but clearly an improvement in the primary endpoint of PFS. Now, one of the interesting things when you compare these 2 antibody-drug conjugates, trastuzumab deruxtecan, which we just talked about in DESTINY-1 and DESTINY-3, is the major concern is interstitial lung disease with a small number actually developing severe pneumonitis. You can also see that with SYD985, although the grade of pneumonitis is generally lower and no high-grade pneumonitis was observed. On the other hand, there are patients who develop eye disorders or eye symptoms. Conjunctivitis and keratitis was something that occurred with some frequency in those patients getting SYD985, requiring either dose modification or mitigation measures for dealing with that symptom. One of the key questions will be with all of these antibody-drug conjugates, if you were to receive, say, trastuzumab deruxtecan, will you then still respond to SYD985 or TDM1? And we'll get more data regarding those recommendations as we look at these trials and as they mature. Now, the other category of drugs are small molecules, tyrosine kinase inhibitors. The NALA trial has been around for a while. We've seen the data from this trial. Again, these are patients with metastatic disease who had at least 2 prior lines of HER2-directed therapy for metastatic disease. And in this trial, asymptomatic and stain-pool brain mets were allowed. And the comparison was neratinib capecitabine or lapatinib capecitabine, going back again to when that was sort of the next therapy after trastuzumab, so this dates this trial. And because the early experience with neratinib had significant, often prohibitive diarrhea associated with it, loperamide was added to this regimen. Subsequently, we found that slow dose escalation of neratinib from the start can decrease the risk of severe diarrhea. Also things like budesonide, as well as colestipol. There are a variety of things that can be done, but a starting point is generally loperamide. As you know from the NALA data, there was about a 2-month improvement in PFS favoring neratinib, and there also seemed to be a decrease in the need to deal with CNS events. So in this trial, as mentioned earlier, there were about 100 patients who had CNS metastases at baseline. The progression-free survival in those with CNS disease was similar to the overall cohort, and an improvement of about 2 months. And similarly, overall survival was about the same, and needing to intervene for brain mets was actually decreased, or the number of patients needing it over a 12-month period was less with neratinib than with lapatinib, again suggesting that there is a CNS effect from this small molecule. Now, moving on to the newer oral TKI that's come on the scene, we have the HER2 CLIMB data, and this involves tucatinib, which up on the left you can see that tucatinib has an IC50 for HER2 that is a very low, whereas for off-target effects such as EGFR, it is not as specific for that. So again, this may demonstrate or explain why there may be fewer symptoms, off-target symptoms, compared to neratinib and lapatinib, where there's a greater avidity for EGRF. In the early phase trial of tucatinib, capecitabine, and trastuzumab, again, heavily pretreated patients, response rate was high, 61%, but also within that group, there were patients with brain mets. There were a small number who had brain mets, And there was evidence that there was actually clinical activity of the drug in the brain. And that, of course, led to the HER2 CLIMB regimen, which was a randomized trial, 2-to-1 randomization between capecitabine, trastuzumab, and tucatinib, or capecitabine and trastuzumab. And in this trial, they actively encourage patients with CNS Mets to participate, almost 50% of the patients, including 22% who were untreated, as well as 18% who were treated but had progressing disease. These patients in this trial, of course, had metastatic disease, and they had disease progression following pertuzumab, trastuzumab, and TDM1. For the overall trial, not focusing on brain mets, but the overall results of this randomized trial, there was a very clear benefit from the inclusion of tucatinib with capecitabine and trastuzumab, with 1-year PFS almost 3-fold higher with tucatinib, and the median PFS statistically significantly favoring tucatinib, a 2-month advantage. If you look at the overall survival, again, for the entire population, again, clear separation of the curves early on, a reduction in the odds of dying of about 34%, and at the 2-year overall survival mark, it's about 20% greater with capecitabine, and the median overall survival is about 5 months greater with the inclusion of tucatinib. So for the entire group, a very clear advantage for tucatinib. But one of the interesting things, and Nancy Lynn and others have talked about this a great deal, when they teased out the data in that 48% of patients who did have brain mets, starting with the entire population, both active and treated stable mets. CNS PFS, so no progression in the brain, or overall survival, again, clearly and very dramatically favored the inclusion of tucatinib. And in the patients with active brain mets on the bottom, so keeping out the ones with stable disease, it's very clear that you can double the CNS PFS with the inclusion of tucatinib. Very clear evidence that it has brain activity as well as overall survival. And then if you look at objective measures, although not surprising, most patients didn't have a CR in the brain, partial responses were seen in 40% of patients, and the duration of response in the brain went from 3 months to 6.8 months. So very clear activity in the CNS. Now moving on to another new drug that was approved at the very end of last year, margetuximab. It's a bioengineered antibody that's directed at HER2. And what's interesting about this is we recognize that there are activating receptors on immune cells such as macrophages and natural killer cells. And these are referred to as CD16A. And there are also inhibitory receptors on macrophages and antibody-presenting cells like dendritic cells, which can have an inhibitory effect. So the antibody with margetuximab was bioengineered, so it had greater avidity for the activating receptor and decreased avidity for the CD32 receptor, which can decrease the immune response. So again, this is a play on activating the immune system. So again, margetuximab, the FAB portion is very much the same, but it's the FC portion of the antibody that was bioengineered for the properties I just described. And as you can see in the table on the right, for the activating receptor, margetuximab markedly greater avidity for that receptor and markedly decreased avidity for the inhibitory receptor. So again, this may activate the immune system. And in the SOPHIA trial, which is described here, trastuzumab chemotherapy or margetuximab chemotherapy in patients with advanced disease who had progressed with prior treatment, including pertuzumab and TDM1, as well as trastuzumab. Numerically, there was a very modest improvement in PFS, the primary endpoint, with margetuximab compared to trastuzumab. However, if you look at the carriers, the F allele carriers, the improvement in overall survival is more striking, about a 4-month advantage. And the final results of this trial, at least the final overall survival results, will be presented at San Antonio in December to see if these results hold up. So this drug was approved last December, and it's just making its way onto the market and starting to be used. A great deal of work is being done with this, including trials in the neoadjuvant setting as well as combining it with immunotherapy. Just to touch on some of the newer things that are coming along, there are bispecific antibodies, and I refer to this in the legend as a chemist's Lego set, because as you can see by the diagrams, medicinal chemistry can make these antibodies in a variety of ways, altering the FAB region, altering the FC region, having two different targets on the same antibody. And there are a plethora of these kind of drugs in development, including some that have already been involved in phase 1 or early phase 2 trials, some of which we only have preliminary results. But as an example, ZW25, a bispecific antibody that targets two different domains of HER2, and there is early results from a phase 1 trial showing about a third of patients respond who have gotten prior therapy. There are a variety of other drugs that are bispecific that are also being developed. We are working with one ARX 788, which is an antibody drug conjugate. The payload is a tubulin inhibitor. And again, in patients who have had significant prior therapy, there are responses, as you can see on the left. And with the the spider plot on the right, some of these responses are quite prolonged. This is just a partial list of antibody drug conjugates either in development or that have been approved. Again, we're going to hear much more data in the coming years about these different drugs. And the big challenge, of course, is how do we integrate them? How do we sequence them? And the final piece I just want to touch on is the notion of the concept of combining HER2-directed therapy with immunotherapy. And the rationale for this is, of course, that we originally had this concept that trastuzumab targeted HER2 cells, positive cells, and something magically happened and the cells were lysed and they died. But we know that not only is antibody-dependent cellular cytotoxicity part of the mechanism, but using HER2-directed therapy causes increased antigen release from the tumors. You have more antigen presentation on things like dendritic cells. There's an increase in the number of CD4, CD8 T cells, which are HER2 specific, and you also get the development of endogenous anti-HER2 antibodies. So there are multipleiotropic effects with these agents, and that really leads to the rationale for combining HER2-targeted therapy with immunotherapy. And if you look at some of the clinical trial designs, we don't have time to discuss it at length. For instance, the K2 study, which was presented by Leisha Emmons last year, or 2 years ago at ESMO, combined TDM1 and atezolizumab. For the overall population, not much of a difference, as you can see, with respect to PFS or overall survival. But if you were PD-L1 positive, the addition of atezolizumab seemed to enhance PFS and overall survival. And an ongoing NRG study looks at the combination of pertuzumab, trastuzumab, paclitaxel, a Cleopatra-like regimen, either alone or with the addition of atezolizumab. And this is a trial that will hopefully determine whether we can enhance the first-line therapy we commonly use with the addition of immunotherapy. So how I would sum up things is that we do have still remaining and still standing a gold standard for most patients in the first-line setting. That is a Cleopatra-like regimen with the taxane, trastuzumab, and pertuzumab. I didn't discuss it all today, the combination of endocrine therapy with HER2-directed therapy. This would be an appropriate choice for some patients, but again, most patients are going to get chemotherapy with HER2-directed therapy because of the survival advantage. Currently, if you look at the August NCCN guidelines, TDM1 is still standing, but with the DESTINY-3 data presented a week ago, this may change, and of course, tucatinib may be appropriate for some patients. In the third line and beyond, we have a number of different treatment choices. Again, this will be in flux with the DESTINY-3 data, and the question will be, do other antibody drug conjugates work after you've received one already? And then we have combinations that include tucatinib or neratinib, more recently margetuximab, and perhaps very close is SYD985, another antibody drug conjugate, and data that will be emerging with the combination of HER2-directed therapy, targeted agents, and immunotherapy. So with that, I thank you, and I will be happy to answer questions.
Thank you very much, Professor George, for this elegant presentation. And now the floor is open for any questions. Okay, Dr. Merhat.
Thank you. Thank you very much, Professor William, for this informative presentation. Actually, I'm a radiation oncologist, and you presented some images for patients with brain metastases successfully managed with trastuzumab and capecitabine. And my question is, was there any role of radiation therapy in these patients?
Well, again, we're not saying that, I wouldn't suggest that radiation doesn't have a very important critical role in managing patients. There are circumstances where, if there's very limited, very tiny disease, the appropriate first step may still be radiation therapy. We don't have a lot of data, certainly with concurrent, simultaneous use of, say, these agents with radiation therapy. But I think for any patient where there's very significant bulky disease and there's some urgency, radiation still plays an important role. I would never say that systemic therapy is the only way to manage patients with brain mets. What these agents do offer for the first time is in those patients where radiation therapy has already been used and where you have a limited amount that you can still deliver, we have an opportunity to use systemic therapy that does appear to have some activity in the brain. So the HER2 CLIMB data is pretty compelling. At the same time, it's not a cure for brain mets. We've managed to demonstrate that you can prolong the time until the disease progresses, you can improve survival, but we still have a lot of work to do. These agents do not cure brain metastases.
Thank you, Professor William, for your elegant presentation. My question, we are in era of neoadjuvant therapy in HER2 positive patient. If the patient achieved CR after pertuzumab Herceptin and no CR, a pathological CR, and disease-free survival for more than 3 years, can reintroduce the same combo after this duration, or I have to follow the guideline with DTM?
So I think that's a good question, and what I would say is that what many people do in practice is guided by the interval between exposure to the last therapy. So in your example, if a patient had a quite good response to preoperative HP therapy with chemotherapy, and then many years go by, I would consider that you could revisit the idea of Herceptin Perjeta again. Whereas if the interval was very short, then I would be more inclined to switch to a different therapy.
Okay, thank you very much. Very short comment from your side. I'm a little bit believer of hormonal treatment with anti-HER2 in triple positive disease. So you mentioned in your first line recommendation that this will appear in some disease categories. So can you please give us a clinical scenario in HER2 positive disease that I cannot or I may omit chemotherapy?
Sure. So I think that we can't discount the survival benefit which we see with the Cleopatra regimen. So we're actually making people live longer by using that treatment approach. So that would be the preference. But that said, there may be patients who have, maybe less functional or have a performance status or comorbidities, or the amount of bulky disease they have is very minimal. Maybe they're only bone-only disease or something. In that setting, your desire to treat them with chemotherapy may be less. As a result, that may be the kind of patient where I would consider endocrine therapy with HER2-directed therapy and avoid chemotherapy. But for most patients, just to be honest, for most patients, because of the survival benefit, I would typically use chemo HER2 therapy, but there are exceptions.
But not in adjuvant setting. I cannot dare enough. I cannot be brave enough, or I cannot dare enough to give anti-hormonal and anti-HER2 in adjuvant setting. I mean, if the patient is postmenopausal, node negative, very T1 tumor, and can I depend on dual blockage of HER2 with some aromatase inhibitor?
Well, the idea is attractive because we all have those patients where we wonder, do they really need all that therapy? And for those kind of patients, what we've typically done is the Sarah Talani, who just spoke, the TH regimen. That's a very common recipe that we use in the States. I would tell you that if it was an older patient where you did have some concerns about giving them chemotherapy for all the reasons I mentioned, that may be somebody where I started with paclitaxel trastuzumab, and at the first hint of any difficulty tolerating the treatment, I would abandon the taxane and just continue anti-HER2 therapy, and if they're ER positive, add the endocrine therapy.
Thank you.
Hi, Professor Kadisher. Thank you very much for your presentation. I have a question which is opposite to Professor Dr. Hiba. If we have a HER2 positive but hormonal negative, and this patient has a comorbidity, cardiac comorbidity with a very low ejection fraction that doesn't permit us to give those anti-HER2 with these side effects or cardiotoxicity. So what can you do in this situation?
So if it's a patient where their cardiac function is so poor that you cannot really give any form of anti-HER2 therapy and they're ER negative, you're sort of limited in what you're able to do. I mean, of course, you can give chemotherapy alone. You could, try to introduce, any of even the TKIs have some potential for affecting cardiac function. So I would be pretty cautious. If you're describing somebody that really has prohibitive cardiac problems, what you're really saying is that patient has a greater risk of dying of heart disease than they do of breast cancer, in all likelihood, by the description you have. So if we follow the old adage, do no harm, it may be a decision deciding if this patient's low enough risk to either not treat adjuvantly because their heart disease is so bad, or give them a very gentle treatment, avoiding anti-HER2 therapy entirely.
Okay.
Yes, I have addition for question to Professor Naveen to you, please. Do you think that testing of TELs may help us to de-escalate the anti-HER2 for these patients with a lot of comorbidities, to have shorter time or for anti-HER2? Do you have think that testing of tumor infiltrating lymphocytes, TELs, may help us to de-escalate the anti-HER2 for those patients?
It's possible. I don't think we have data yet that shows us that is a way of stratifying patients and allowing us to de-escalate. Of course, it's an interesting idea. And certainly in the adjuvant setting, we've had data that suggested shorter periods of anti-HER2 therapy may be just about as good, maybe not as good, but just about as good. And there was a meta-analysis presented at ESMO just a couple of weeks suggesting non-inferiority again. So for those patients where you have some concerns about comorbidities, that would be the kind of patient where I would probably limit their anti-HER2 therapy if you were brave enough to start it.
Sorry, Dr. William, I just want to ask you a very practical question. In spite of the availability of the anti-HER2 new therapies, now we don't have all of these drugs for our patients. Do you think it's acceptable to continue the anti-HER2 new used for the treatment of metastatic disease like trastuzumab or lapatinib and after progression with changing the line of chemotherapy combined with the anti-HER2/neu. Especially there are some small trials saying if we can continue the trastuzumab after the progression with changing the other binder, we can get some response.
Yes. So I think that if we were to go back in time not that far, you know, whatever, 5, 7, 8 years ago, before we had, you know, the introduction of many of these new drugs that are becoming available, the strategy after Herceptin, trastuzumab, the next thing would have been lapatinib, and that was it. We didn't have anything else. There was nothing else. So what we usually did was we changed out the chemotherapy and continued trastuzumab. And we have data from von Minkwitz, you know, a decade ago, showing that, you know, switching out the chemotherapy and continuing trastuzumab did confer a benefit. I would always try and target anti-HER2 therapy. So even if you're limited in what you have available in terms of the new drugs, I would switch out the chemo and I would consider trastuzumab therapy. And at each progression, as long as you had some other option and the patient was functional enough, I would continue anti-HER2 therapy.
Okay, thank you, sir, for this nice presentation. And come back to the metastatic patient with HER-positive disease with, in addition, CNS metastasis. If this patient receiving before the combination of trastuzumab and bortezumab, and now we have CNS metastasis, which would you prefer, to go for TDM1 or take eyes for such patient?
So if a patient progressed on pertuzumab, trastuzumab with brain mets now, is that correct?
Yes. And receiving trastuzumab combination before.
In that setting, you know, one of the decisions would have to be, you know, how severe and how many are the brain mets that are present. If they were very tiny, not clinically bothering the patient, we may switch the therapy, systemic therapy, and as already mentioned, today it's probably TDM1, but tomorrow it could be trastuzumab deruxtecan. And we would consider radiating those spots if they were quite small, if they were, you know, potentially going to cause a problem. If a patient had a fairly big disease or lots of brain mets, we may be more inclined to switch to a tucatinib-based regimen. But I think that as long as what's driving things is disease below the neck more than what's above the neck, we would make our decision based on what is the best therapy for the visceral disease. And the data we have from DESTINY-3 now would suggest that that is clearly better than TDM1. So I think that we would still have to take into account what are the complications that may arise from the CNS disease, but that may be able to be managed systemically or with radiation therapy. And, you know, we would obviously confer with our colleagues in radiation oncology to get their opinion as well.
Thank you very much, Professor William. And now it's my pleasure to present Professor Tamer Rifat Abdurrahman. He is Associate Professor of Radiation Oncology at Chicago University. He's a Medical Director of Loyola, I hope I pronounced it rightly, Loyola Medical Center for Cancer and Research Radiation Oncology Center. He's a Director of the MRI Guided Radiation Therapy Program. Please, Dr. Tamer.
Hello everybody, my name is Dr. Tamer Rifat. I am a radiation oncologist at Loyola University in Chicago. I first would like to start by thanking the organizing committee for inviting me to this prestigious conference. Today I'm going to discuss the strategies for de-escalation of radiation therapy in women with breast cancer. So we all know that radiation therapy is very well established as an adjuvant therapy for women with breast cancer, especially after breast conserving surgery or lumpectomy. It is associated with less likelihood of local recurrence and likely overall survival advantage. That was proven both in women with node positive and node negative disease. Radiation therapy post to the lumpectomy cavity was shown to decrease the likelihood of recurrence. However, it comes with the cost of increased likelihood of fibrosis, especially if you use higher doses of radiation therapy like 16 gray. In our practice, we keep this to women with closer margin or focally positive margins who wouldn't go back for resection. Our standard post-radiation is 10 gray. So for many, many years, since the 1990s, standard of care after lumpectomy has been whole breast radiation therapy for approximately 5 weeks, followed by 1 week of post to the lumpectomy cavity, kind of one size fits all. Treat everyone after breast conservation, treat the whole breast, do not treat the lymph nodes, and do not worry about side effects. Now, in this presentation, we might present some data showing that this might not be the optimal way to treat women with breast cancer. For those of us who treat breast cancer, myself included, we clearly see patients with smaller size tumor, node negative disease, comparing similar studies in different eras, 1970s and 1990s, early 2000s. You can see that the mean tumor size has dropped, likelihood of node negative disease is higher. Radiation therapy had to evolve over the years as well, going from the classical fractionation of 25 to 28 fractions to hypofractionation to partial breast irradiation or APPI or IRT. So what are these strategies and what are we going to discuss in this presentation? How can we de-escalate radiation therapy? We can utilize fewer days of radiation. That's what we call hypofractionation. We can aim at treating smaller sized targets, what we call partial breast irradiation. Or we can do both. We can utilize fewer days, smaller targets, what we call ATPI or accelerated partial breast irradiation. And we need to ask ourselves if we need to treat every woman after lumpectomy with radiation therapy or not. Now, in this presentation, we should have also, if we are to have the time, go through the strategies to decrease the side effects or decrease the radiation to organs at rest, including DIPH or prone position, using some systems like Vision RT or Align RT, particle radiation like protons. I'm not going to go through that given the limitation of time. I'm also not going in this presentation to discuss when can we consider omission of nodal radiation or using high tangents instead of comprehensive nodal radiation. And I'm not going to go into the debate of post-radiation therapy and if we should offer post-radiation therapy for every woman. The short answer is no. There are some guidelines, older than 70, earlier disease, smaller size good biology tumor. Those are the ones that we might consider omitting radiation therapy. Post-radiation therapy, let me say. I'm going to focus on these strategies here, given the interest of time. So fewer days of radiation therapy. Until early 2000s, most of the radiation oncologists in this country were utilizing the conventional 50 grain 25 fraction or 50.4 grain 28 fractions whole breast radiation therapy after lumpectomy. We had a couple of studies coming from England and Canada. START-B trial is a British study, 2,200 women, T1 to T3, not N0 to N1 breast cancer patients. There was no difference when they compared 40 gray 15 fraction of 2.67 gray per fraction for breast radiation to the conventional radiation therapy. No difference in tumor recurrence, and actually the adverse events were even favorable in the hypofractionated arm. Canadian protocol, 42.56 grade 16 fraction, comparing it to the conventional fractionation, 1,200 women, more favorable biology and stage 3, 1, 2, and 0 breast cancer. Again, no difference in the local recurrence, survival, or significant side effects. Remember, this is a study where they discussed the separation or the size of the distance posteriorly of the breast. If it's more larger than 25 centimeter, meaning women with larger sized breasts were not eligible to this study. They were concerned about some heterogeneity in the radiation plan, given the older techniques they were using back then. So 40 and 15, or I would say 42.56 and 16 has been pretty much the standard of care in most institutions in this country. Recently, we got the results of the Fast Forward trial. 4,000 women, so a larger study, rich study, comparing T1, T3, N0 to N1 breast cancer women after lumpectomy or mastectomy. And they had 3 arms in this study. 40 gram 15 fraction, which is pretty much the standard of care, to 27 gram 5 fraction or 26 gram 5 fraction. Remember, this is all 3D conformal. You don't need IMRT. IMRT is not a standard of care in all breast radiation right now. And I believe it should never be. So the study was published last year. 5-year data showing that there was no statistical significant difference between the 3 arms. Cosmesis was worse in the 27 gram 5 fraction arm. Authors recommended that 26 gram 5 fraction is a suitable and appropriate alternative to the 40 gram 15 fraction. Now, part of the publicity of this study is that it was published at the year of the pandemic. That's when everybody was really very worried bringing patients over to our radiation clinic. Patients wanted to be in the hospital for fewer days. Our staff didn't want to stay longer. So I would say many centers, especially because of the COVID pandemic, started to convert their standard of care from 42.56 gram 16 to 26 gram 5 fractions. And as we are now able to go through the pandemic and have better strategies to protect our patients and staff, many have converted back to the hyperfractionation, 20 in 16 fraction, 42.56 gray in 16 fractions. Many are still relying on 26 gram 5 fractions. In my practice, in my daily practice, I have a long conversation with these patients. While this data is very solid, the problem is you have only 5 years. Would it change after 10 or 15 years? Well, we don't know. It may not, it may change. And remember, those are patients with a very favorable outcome. And you do not need to compromise their local control or change your standard of care or practice based on 5-year data. So my own practice, I discuss that. I keep this to women who are older, usually older than 75 or 80, who are still in need for whole breast radiation. They are not eligible for partial breast radiation given like T2 or larger T3 tumor. Those are the ones that I wouldn't feel comfortable treating with partial breast. And I'm saying partial breast because we now have 10-year data for partial breast studies that we are going to discuss later in this presentation. Or those who would say, you know what, I will never come if you are to offer me 15 days vaccination, and I don't think I should get any radiation therapy. In these women, 5 days would be better than nothing. I think in a basic clinic, if your patients understand that the limitation of this study is the shorter follow-up so far, that's a perfect alternative in a low resource situation. Now, what about smaller target radiation therapy? So START study, the British study, Canadian study, Fast Forward, all of those utilized whole breast radiation therapy. Fewer days, similar outcomes, better similar cosmesis, so there was no really significant difference between the conventional 5 weeks or 5.5 weeks to 3 weeks or 1 week, given the limitation of only 5-year follow-up data. Now, Portlow study was asking a different question. Do we really need to treat the whole breast with radiation therapy? So the advantage of these studies that unlike the APPI studies that we are going to discuss later, it is asking one question: is partial breast radiation as effective as whole breast radiation? They did not alter their fractionations. They still used 40 gray, 15 fraction. There was one arm like 36 gray to the whole breast and 40 gray to the partial breast. But the question was simple: is partial breast same like treating the whole breast radiation when it comes to outcomes, and what about adverse events? The way they define the partial breast radiation, they controlled their lumpectomy bed, expanded that by 1.5 centimeter to create their CTV, and then 1 cm for PTV. Of course, probing everything outside the breast, and chest wall, we're going to go through that later, but that's pretty much the same way we contour our partial breast radiation patients. Outcomes were similar between the partial breast and whole breast radiation. It was not statistically significant. Most of the adverse events were similar. So this study shows that at least at 5 years, there was no statistical significant difference in the control or cosmesis between whole breast and partial breast radiation therapy using the hypofractionated, which I would call now the conventional fractionation. It is very, very unlikely, and in very specific situations when you would elect conventional 5 or 5.5 weeks course of radiation to women after lumpectomy in this country right now. Okay, what about both? How can we utilize fewer days of radiation and smaller target volume? That's what we call accelerated partial breast radiation therapy, or APPI. And there are many, many different forms for APPI. You can do that with brachytherapy, either mammocyte, which I don't think anybody is using right now, or interstitial brachytherapy. You can do that with external beam radiation therapy, 3D conformal or IMRT. You can use that through intraoperative radiation therapy. So RABBIT study was one of the earliest studies published. Canadian study, 2,100 women older than 40 after lumpectomy, comparing whole breast radiation therapy with or without boost to ABPI, which was 38.5 gray in 10 fractions, BID, 6 hours apart, daily fractionation. So 10 fractions over 5 working days. And at 8-year follow-up, there was no difference in the likelihood of ipsilateral tumor recurrence or in-breast recurrence, 3% in the APPI arm and 2.8% in the whole breast arm. However, cosmesis was worse. As you can see here, while acute side effects was actually better in the partial breast arm, this is most likely related that most of the APPI adverse events would happen after the patient is done with their 5 days course of treatment, so they were not really seen. However, the late adverse events was definitely worse. As you can see here, in duration of fibrosis, 20% grade 2 in the APPI arm compared to 4.5% in the whole breast arm. Same applies for pretty much everything. For any late toxicity, 27, 28% in the partial breast arm compared to 12% only in the whole breast arm. One of the reasons that that's an older study, larger margins, primitive techniques of treatments. Then we had that Jack-Estro study, which was a brachytherapy study, 1,100 women older than 40, non-inferiority study, tumors smaller than 3 centimeter, mostly node negative and 0. Only 1% had microscopic disease, and women were randomized to whole breast radiation therapy, 50 gray plus 10 gray boost, compared to multi-catheter interstitial APPI. Fractionation utilized was 32 gray in 8 fractions BID. And there was no difference, no statistical significant difference again. The likelihood of tumor recurrence between APPI and whole breast radiation therapy. 1.4% in APPI compared to 0.92%. That was not statistically significant, and actually adverse events was in favor of APPI in this study. Florence Study is a study that many of us who treat women with APPI would use as a reference and one of the favorable protocols. Smaller study, single institution, Florence University in Italy, women older than 40, tumor less than 2.5 centimeter, clips need to be placed, no extensive intraductal component, larger margins, low risk invasive carcinoma or TCIS, and no history of cardiac or lung disease. Women were randomized to whole breast radiation 50 gray plus post 10 gray all APPI. APPI, they utilized IMRT 30 gray, 5 fractions, so single fraction per day, which is much, much favorable to the patient compared to bringing the patient twice 6 hours apart with the Canadian protocol, rapid protocol, or the V39, as we'll discuss later. And they used smaller margin compared to most of other external beam-based APPI. So only 1 cm margin expansion around the lumpectomy to create CTV, and another 1 cm margin to create BTV. We have 10-year data of these studies that was also published last year, and there was no statistical significant difference between whole breast irradiation and APPI at 10-year regarding ipsilateral tumor recurrence, local regional recurrence, distant mets, or overall survival. And actually, toxicity was in favor of APPI. So remember, this study used advanced technique, IMRT, smaller margin, CTV expansion was only 1 cm, not 1.5 cm. Still, they had BTV margin, and it came with a great results. We have 10-year data for this study. Now, B39 is one of the largest, if not the largest, APPI study. It's an RTOG study, very wide range for eligibility for this study. Stages 0, 1, or 2, status after lumpectomy. They allowed women with up to 3 positive lymph nodes, very young cohort of patients, more than 18-year-old, and tumor size was 3 centimeters. 4,200 or 4,200 women were enrolled in this study, and randomization with either whole breast radiation, 50 gray, 2 gray per fraction, 50.4 gray in 28 fractions, which was the standard back then when they designed this study, with optional post, compared to APPI, either utilizing brachytherapy, 34 gray, 3.4 gray per fraction BID, or external beam radiation therapy, 38.5 gray per fraction. And remember, all these women had 3D conformal radiation therapy, no IMRT. These were the expansion. So if this is your lumpectomy cavity, you expand that by 1.5 centimeter to create your CTV. You crop it 5 millimeter from the skin, and you do not expand your CTV beyond the muscles of the chest. And then you have 1 cm expansion around the CTV, that's your PTV. However, you have another volume called PTV eval, which actually is overlapping with the breast eval, cropping 5 millimeter from the skin, not extending beyond the muscles here, the chest wall muscles. And that's where you prescribe, like you prescribe your dose and evaluate your dose here. However, you open your beams for 3D conformal planning utilizing the PTV. Or you can do brachytherapy, interstitial brachytherapy, or mammothectomy. Well, as I mentioned, if you look at the cohorts of patients used in this study, you will find that 40% of women were premenopausal. You had 10% with node positive disease. You had 27% with high-grade disease, 5% lobular carcinoma. So those are usually not the typical cohort of patients that you would use or would in your clinic you will elect partial breast radiation. So it's not surprising that the study was a negative study. It did not meet the non-inferiority cutoff points that they aimed for. Saying that numerically the difference was not huge, 3.9% local recurrence in whole breast radiation compared to 4.6% in APPI. all them, and that was not planned, but every sub-analysis favored whole breast radiation in the study. Cosmesis was not much different. So as you can see here, only these 4 studies included approximately 7,000 women. Most of them utilized 3D conformal and do not need IMRT for APPI. We have at least 2 of them is approximately 5,000 patients with 10-year data, solid data. And if you look at toxicity, it's pretty much the same, except for the B39 outcomes were similar between APPI and whole breast radiation. Now, I'm not going to spend a long time in IURT, but 2 famous studies, Target and Elliott study. Target studies were included 3,400 women comparing whole breast radiation to intraoperative radiation therapy. It had 2 strata. One of them, which they called the pre-pathology. At the time of lumpectomy, they inserted the bone and they gave 20 gray to the surface. Post-pathology, they brought the patient back after they had the final pathology report to treat them. Post-pathology, nobody's doing anymore. It was negative. It was not it did not meet the non-inferiority. Long-term data says otherwise. However, if you are to do IRT, usually we do that at the time of surgery. In my practice, given the uncertainty around the outcomes, I offer that to women who would never come for partial breast radiation therapy or for fast-forward protocol after lumpectomy. I would still believe that giving radiation therapy based on this data is better than mission of radiation therapy, and I'm going to come to this later. The only catch I explained to them that at the time of lumpectomy, we don't have a final pathology report. And in this study, almost 1 in 4 women were called with some negative finding in the final pathology report and needed to have whole breast radiation after they received IORT. So they would consider IORT as like a post happening at the time of surgery. And in my personal experience, when this happened, first it is very inconvenient to these women to receive a phone call from you saying that, hey, I'm sorry, but your final pathology report got like extensive intraductal component or focal positive margins, and you need to come back for whole breast radiation. Plus the side effects I have seen in my own practice is way higher when you do that compared to the just post-operative external beam radiation therapy. Cardiac deaths was less in the IORT arm in this study. Elliott, they utilized electrons, and it was actually a negative study. Not many centers are doing that anymore. So as you can see, for partial breast radiation, you have, it is all over the place. You have different fractionations, you have different approaches, but advantage of whole breast, of APPI or accelerated partial breast radiation, shorter treatment course, smaller target volume. Usually you get favorable dosimetry of less radiation to organs at rest and less exposure to normal breast tissue. Limitations, we still don't have optimal protocol, optimal approach, and there is some uncertainty about it being non-inferior. Like if you look at most of these studies, you will notice that even if it's statistically not significant, those are all non-inferiority studies, which means that you don't need to be first or better. You just need to come second and we'll consider you first. And there has consistently been approximately 1%, numerical 1% higher risk of local recurrence utilizing APPI. Saying that, we have approximately 10,000 women enrolled in different studies. Some of them we presented, some we did not. Comparing APPI to whole breast radiation. That's way more, by the way, than the women that we enrolled when we compared mastectomy to lumpectomy plus radiation therapy. It was approximately 2,000 to 3,000 women. We have 10,000 women data. Most of them are reassuring or non-inferior. In my own practice, I would say that if you strictly follow the ASTRO guidelines for partial breast radiation, so older women, good biology, smaller tumor, low grade, negative margins, I haven't seen problems offering them partial breast radiation therapy either with 3D or IMRT. If you go into the larger population with like younger women, larger tumor, closer margin, positive nodes, I don't see that as an appropriate treatment approach for these women. Now in our institution, and there's been only 1 minute doing that, we have MRI guided machine. So we are able actually to track live during the treatment, the lumpectomy cavity, which result in less set of uncertainty. We can monitor the intrafraction motion. So we contour the lumpectomy cavity, and we presented our program in San Antonio a couple of years ago. That's how we set our patients. So you either place a noodle or a bracket, depending on how large is the size of the breast of these patients. You place the MRI coils on top and beneath these women. And we use only 1 cm margin around the lumpectomy cavity. We do not expand the BTV. We do not expand the BTV, CTV, equal BTV, and we treat these patients. As you can see, our volume is much smaller than the B39 volumes. B39 with 1.5 cm expansion from CTV, from lumpectomy to CTV. We do only 1 cm, and we do not do any extra margins for BTV. My prescription right now is always 30 gram, 5 fractions. I do not bring the women twice daily. I do not do 38.5 BID. And we were able to meet all our constraints with IMRT. However, if you don't have access to MRI guidance, you are still able to do ABPI. You can do that with 3D conformal. You do not need to do COMBEAM, CT, QB is fine for your treatments. You just need BTP margin. So you will add 1 cm BTP margin on top of the CTP. So what is the future direction? There is extreme hypofractionation utilizing EBRT or external beam radiation. These are some data from, and I'm checking the time. Okay, so those are some data from WashU, where they use single fraction with EBRT MRI guidance with reassuring results. And I'm going to skip that for the interest of time. Regarding omission of radiation therapies, there has been a number of studies comparing adjuvant radiation therapy to omission of radiation therapy. Well, long story short, given the time limitation, none of these studies showed that omission of radiation is as good as adjuvant radiation therapy. You can debate how much benefit do you have, but none of these studies showed that you should omit radiation therapy. So now, given the options that we have, ABPI, or fast forward protocol in 5 days, or intraoperative radiation therapy, I still believe that giving adjuvant radiation therapy should be the way to go in most women with breast cancer. So that's an older study, and as I mentioned now, lumpectomy, standard of care conventional over 3 weeks, post for some women. We should not need to treat everybody. Again, I have some reservation about omission of radiation therapy. I see some better alternative. You can treat partial breast for some if they are eligible, nodal radiation for some, and you can actively avoid radiation to heart and lung using PRON, DIPH, line RT, and many other options. So there is no size fits all. Every patient is different, and you can definitely individualize, and you should actually individualize your treatment based on your patient. And at the end, I would like to thank our wonderful team at Loyola University in Chicago, and I would like to again thank all of you for giving me the time to present here, and I hope I'm done. Thank you very much.
Thank you very much, Professor, for this elegant presentation. And now the floor is open for questions.
Yes, if you allow me, please.
Yes, please, Professor Heba.
Dr. Tamer, thank you very much. Very updated and explainable presentation. I will ask you a very general question, have been asked in many conferences. Do you prefer to have accelerated radiotherapy or fractionated according to the type of biology? So is any HER2 positivity or triple negativity influence you? And then if is any other factor like very obese patient or pendulous breast you can omit this fractionated radiotherapy?
Okay, first, thank you very much for inviting me to this conference. So we are running behind our colleagues in medical oncology. We have not yet based our recommendation based on biology. Clearly, there is some data that higher grade, more aggressive biology result in higher likelihood of local recurrence or progression. And those are the women that I wouldn't even debate with them radiation therapy or offer any omission of radiation therapy. As I mentioned in my presentation, there is a number of studies aiming at omission of radiation therapy, older women, luminal A, early stage T1N0 disease. We usually would omit radiation therapy in women with DCIS grade 1 or grade 2 if they are comfortable with the associated risk. And now we do some biological evaluation, decision RT. That's what we do for DCIS grade 1 and 2 to kind of help guide the decision of omission of radiation therapy. We have not been doing that yet in any invasive cancer. And I still believe, based on the many options I presented in this lecture, and it was just not very comprehensive because of the time, that still there is clear benefit for radiation therapy. So whenever we are able to give radiation therapy, I find fast-forward protocol for women with like T2 plus disease or invasive lobular carcinoma or higher grade, where you have to treat the whole breast and you are in a low resource center, or patient wouldn't come for more than a week of radiation. Fast forward is a very reasonable option for them. Partial breast, more solid data over 10 years now, and I'm comfortable offering that for a better biology. Women who would be eligible for APPI criteria, or IORT for the elderly women who wouldn't come for radiation. So between all these options and between the benefit we have seen in every single study with omission of radiation therapy, I don't see yet any convincing reason to omit radiation.
Dr. Ahab has a question, please.
Thank you, sir, for this nice presentation. I would like to ask two questions. The first one, for patient who will receive accelerated breast irradiation, you say that it includes also patient with up to 3 lymph node positive. In this case, what about the regional lymph node irradiation? This number quite
that was one of the eligibility criteria in B39. And talking to the person who designed the study, and I reached out myself to them, how this is possible, right? Because you need to do regional nodal radiation. I understand some center would debate that, with 1 to 3 positive lymph nodes, do you really need to do comprehensive nodal radiation or not? In my practice, I do. I still treat all these women with comprehensive nodal radiation. The reason why they included women with 1 to 3 positive lymph nodes in this study was that they wanted, which I'm not sure if it's very ethical really, they needed more events. They said if we elect only the APPI eligible patients, we might not see any recurrences over the follow-up period. So they opened it to women 18 years and older, while we usually would never offer APPI except for women 50 plus. Opened it for women with up to 3 positive lymph nodes, included grade 3, more than a quarter of those patients had grade 3 disease, and they included some other criteria that actually is not even in the cautionary group based on the ASTRO recommendations or guidelines for APPI. So I do not agree on this. If you are to do APPIs, there is no way to do, of course, comprehensive nodal radiation. So my best guess, they omitted radiation to the lymph nodes in these women, likely they had axillary dissection. Remember, this study was run early 2004 to 2010, and at this point of time, the data from the 11 and other studies did not come, so axillary dissection was not uncommon. So I would expect that was the reason behind including these women. But again, in my practice, I do not recommend, I do not do this. I would never offer partial breast radiation to any woman with 1 positive lymph node or even microscopic lymph nodes.
And if you give regional lymph node irradiation, what is your radiation dose and fractionation?
I'm sorry, say it again?
And if you decide to give for this patient regional nodal irradiation, in this case, what is the prescribed dose and fractionation?
So we do 50.4. 50.4 in 28 fractions, that's what we do. Or 50 and 25. We have not been doing any hypofractionation whenever we offer comprehensive radiation.
And for patient who receive hypofractionation 26 gray over 5 fractions, and this patient you will give after that boost to the tumor bed. It is
That's
about.
a big question. So yes, it depends.
It depends.
Most of them would not. The study included boost, so it was up to the investigator to offer boost or not. I do whenever it's like I just treated a couple of weeks ago a woman who was like 84, had T3 disease, wouldn't come for 3 weeks of radiation, and I offered her 26 and 5, and then I gave her boost 10 and 4 fractions.
10 fractions over 5, 10 grays over 5 fractions. What
4 or
about?
5, it doesn't matter. She wanted less days, so I gave her over 4. But the practice is really very variable in this country. You can give it in 10 and 4 or 10 and 5.
Would you like to use the same fractionation as for the whole breast to the boost also, instead of giving so 26 over 5 fractions, using the same fractionation also for the boost for the tumor bed? What do you think about that, and what much dose?
10 and 4, that's 2.5. I don't think there is any data for 2.6. And then what are you going to do? 10.4 gray. So I think 10 and 4 is reasonable, and it's close to the whole breast fractionation, and that's what I do whenever I offer the fast forward.
Yes,
Okay,
Dr.
thank
Tamer,
you.
I want to ask about the question, to continue with Dr. Ihab question. If you have go to 5 fractions, 26 grays over 5 fractions, then boosting the tumor bed. By this scenario, we are losing the optimization of hypofractionation over 5 days. We are going to give the patients about 13 fractions. And if you can compare it by 13 fractions and give concomitant boost with conventional fractionation or 20.6 fractions per day with concomitant boost, you will give the same regimen with a much less dose per fraction with concomitant boost in the last 5 fractions. And you are achieving by this way the same way to give 26 gray over 5 fractions, then followed by 8 fractions for the boosting. By this way, you are losing the option of hypofractionation over 5 days. You prolongate the fast forward another 8 fractions for a boosting. So I think the fast forward should be allowed, as you said in your presentation, for a highly selected patients not needing the boosting with a favorable biology of breast cancer and not need for nodal irradiation. Do you think that this highly selection should be categorized, because you have many centers out of clinical trials, and inside clinical trials after fast forward they applied in the COVID era fast forward for all patients, even patients needing for boosting and nodal irradiation? Can you comment on this?
I understand where you come from, and actually even in this country, in this city, and in other comprehensive cancer centers, they utilize fast forward 26 and 5, and it is very hard for them to come back now and go to the hypofractionation. What I would say is the fast forward allowed boost. So I think we have evidence that if you would like to do this, you can do it with 26 and 5 and then boost. My biggest concern about the fast forward is that we have only 5-year follow-up data. So actually when I offer it to any patient, I clearly tell them I am actually more comfortable offering 30 and 5 with partial breast if they are eligible based on the APPI guidelines from ASTRO over the fast forward, just because I don't know what's going to happen in 10 years. Most likely it might not change, but it may also change and might not be non-inferior anymore. So I would offer fast forward only for a subset of women who would never come for 3 weeks and who are not eligible for APPI. That's my own practice. Is there other centers in the city and in this country offering it as a standard of care right now? Yes, there is, but not us.
Yes, I think also I noticed a very interesting picture in your presentation, that's women doing MRI in the supine position, not a prone position. And this technique, I asked our radiology about this technique. This technique needs to have a prosthesis of the chest wall to have the, good imaging in the periphery of the breast. Do you think that this technique will offering a better delineation in the supine position by using MRI?
That's a wonderful question. Actually, our colleagues in Cornell, I am a member in the Breast Consortium for MRI-guided breast radiation. They do it in prone position. Our concern in the prone position is a couple of things. We are in the Midwest in Chicago, so obesity and overweight is very common, and the MRI is very narrow, so it's almost impossible to fit our women in an MRI tunnel and treat them in prone position. The other issue is that how can you guarantee the breast is not moving much? While in supine position, if we go back to my slides, you will find that if the woman has a smaller breast, we use a noodle, and if she has a larger breast, we created a bracket in our center, so we keep the coils with the MRI on top and beneath that, and we have excellent visualization. We actually offset the patient on the table, because the table doesn't move much within the MRI board, right? So we offset the patient and we get a direct visual on the lumpectomy cavity, and that's what made me very comfortable on any PTV expansion in these women. It's all CTV only. It's a completely different approach, and I didn't go deep into this, first because I know the technology is not yet available, and second because of the interest of time.
Thank you, Dr. Tamer. And I have two questions, but I won't ask out now. Maybe I will send it to you and find the answer. And of course, thank you very much, and send our best regards for Dr. Mohammed Sheikh. Okay, thank you.
Thank you very much. Bye.
And now our next speaker will be Professor Julie Grallo. Professor Grallo is the current clinical medical officer and the executive vice president of ASCO. She was Jill Bennett Edward Professor of Breast Cancer at the University of Washington School of Medicine and Professor of Clinical Research at Fred Hutchinson Cancer Research Center, as well as the Director of Breast Medical Oncology of the Seattle Cancer Care Alliance. She is going to talk us about optimizing adjuvant systemic therapy in hormone receptor positive early breast cancer who needs chemotherapy. Professor Grallo.
Hello, I'm Julie Grallo, the Chief Medical Officer for the American Society of Clinical Oncology. Today I'm going to discuss how we optimize adjuvant systemic therapy in our hormone receptor positive early stage breast cancer patients with a specific question of who needs chemotherapy. Within the treatment of our hormone receptor positive early stage breast cancer patients, we have multiple pieces of the treatment puzzle to discuss. We have the issue of what's the optimal endocrine therapy. In the postmenopausal setting, tamoxifen versus aromatase inhibitors. In the premenopausal setting, who benefits from the addition of ovarian suppression? We have questions about the duration of endocrine therapy, who needs longer, and new data asking about Cdk46 inhibitors being added to endocrine therapy. We have the role of adjuvant bisphosphonates and who benefits from these, and who needs chemotherapy, the topic of this discussion. With the availability of screening, when it's available, we have increasing numbers of smaller tumors, including smaller ER-positive tumors, and these overall have a good prognosis. Most small, early-stage ER-positive breast cancers do fine with adjuvant endocrine therapy alone without chemotherapy. The issue is that some will relapse distantly, leading to death, and we need to try to figure out who these are. The question is, who really benefits from chemotherapy? Sorting out the subset of patients and tumors who remain at high risk for distant recurrence despite good adjuvant endocrine therapy, and also determining in that group whose risk is significantly reduced with chemotherapy. There are consequences of both overtreatment and undertreatment with chemotherapy in this setting. We have classic clinical pathologic factors used in decision-making for adjuvant systemic therapy in this setting, including tumor factors, the different subtypes of breast cancer, the ER/PR positive, HER2 positive, triple negative subsets. We use anatomic stage, such as lymph node status and the size of the tumor, as well as the spread. We use tumor grade in some settings. Ki-67 and other markers of proliferation and mitoses can be useful. And we have patient factors in selecting optimal therapy in the adjuvant setting: the patient's age, menopausal status, comorbidities, and his or her personal goals and acceptance of risk-benefit of a given treatment. I'll just point out that the most recent ASCO-CAP guideline on ER and PR testing in breast cancer, updated in 2020, has come up with this new ER low category that should be reported, mainly because it's acknowledging that we have more limited data on endocrine responsiveness for breast cancers where 1 to 10% of the cells are staining for ER expression. So it states all ER positivity from 1% to 100% of tumor nuclei should be called positive, but when there's 1 to 10% of cells staining, this should be classified as an ER low positive, and it should be reported on the pathology report in this manner. Similar principles apply to PR testing in addition to ER testing. We've had a recent update in the last few years of the Ajcc anatomic staging of breast cancer, and the new edition acknowledges that the classic anatomic stage, which really reflects the disease burden, the tumor size, the lymph node status, and the spread, is important, but also features of tumor biology are important in prognosis and selection of adjuvant treatment. So we have 2 stage group options now under Ajcc for breast cancer. The anatomic stage, it can be clinical or pathologic. That's the classic T tumor, N nodes, M metastasis. And we have the new prognostic stage, which should be used when prognostic information is available. And this groups patients with similar prognosis and treatment approaches into similar categories. So this would include the addition to TNM of using ER, PR, HER2, and grade. And it also states that if you have information about multi-gene panels, such as the 21-gene recurrence score, that you could include this in the prognostic stage as well. So let's talk just a bit about multi-gene assays in early stage breast cancer. Well, we know that there are several multi-gene assays that have proven to be prognostic. They aid in determining risk of recurrence, but few of these have really proven to be predictive of the benefit or lack of benefit of a given therapy. So there's a clear distinction between prognostic assays and predictive assays. This is the NCCN's most recent table on multi-gene assays in early stage breast cancer, and you can see that virtually all listed here are prognostic. They can tell us who's at a higher or lower risk of recurrence. But few are predictive of chemotherapy benefit, and the main proven, validated prospectively multi-gene assay is the 21-gene assay, now validated prospectively in the node negative and the 1 to 3 nodal setting. The question is, can we use multi-gene assays to select which hormone receptor positive early stage breast cancer patients benefit from chemo? And can we avoid chemo in those who do not? I'm going to go through a little bit of the data on that 21-gene assay that's now included in the Ajcc staging, if available, and included in the NCCN guidelines. So the 21-gene assay, also called Oncotype DX, has 16 cancer genes and 5 reference genes. You can see that of the 16 cancer genes, they are strongly related to estrogen receptor, HER2, and proliferation. And this will get to my later discussion about if we don't have access to a multi-gene assay, such as this 21-gene assay, can we do a substitute using other more common and easily accessible markers? This is the Taylor-X trial. It was a prospective validation trial of the 21-gene recurrence score assay in the node-negative, ER-positive population. And this trial enrolled over 10,000 patients, ran the recurrence score on all of them, and found that about 2/3 had a recurrence score in the 11 to 25 range, which was a range where we weren't certain if there would be more benefit or harm from chemotherapy. Those who had a recurrence score less than 11 got hormone therapy alone. Those who had a recurrence score of greater than 25 got chemotherapy and hormone therapy, but that middle group we randomized to hormone therapy plus minus chemotherapy to see if there was a benefit. Here are the results published in the New England Journal. There are actually two curves here overlapping each other. There was no benefit for adding chemotherapy in this node-negative, ER-positive, HER2-negative group randomized to having chemo added on top of standard endocrine therapy. No difference between endocrine alone or chemo plus endocrine with a recurrence score of 11 to 25. And this is looking at all four of the arms. Arm A, which is the recurrence score less than 11, endocrine therapy alone, had a 3% distant recurrence rate. Arms B and C, the two randomized arms, had a 5% distance recurrence rate overall, pretty much overlapping the low recurrence score group. Arm D, which was the group who had chemotherapy automatically added to endocrine therapy, had a much higher distant recurrence rate, 13%, despite receiving both chemotherapy and endocrine therapy. And this group is the group in which we need new strategies. Maybe this is a group where the Cdk46 inhibitor or other treatment options should really be explored. Now, some retrospective, kind of after the fact, evaluation was done looking at an interaction between age of the patient, the recurrence score, and the use of chemotherapy. And what was found was that there might be some chemotherapy benefit in women age 50 or less with a recurrence score a bit less than that 25 cut point. And you can see here a subgroup looking at only those patients age 50 or less, where there was some chemotherapy benefit in the 20 to 25 score, and a bit less, but still some seen for the 16 to 20 recurrence score. So the cut point for determining chemo or not in node positive might be a bit lower in younger women. Now the real question here is, was it really the chemotherapy itself that is adding benefit in these younger, presumably premenopausal women, or was it because the chemotherapy caused ovarian suppression, ovarian failure, and that is what was actually adding the benefit? Now moving on to the node positive situation, the RxPonder trial recently presented and impressed at the New England Journal of Medicine looked at 1 to 3 positive nodes. So ER positive, HER2 negative, now 1 to 3 positive nodes. And they took the group with the recurrence score of 25 or greater and took them off study and assumed that they would get chemo with endocrine therapy. But the recurrence score group of 25 or less was randomized to get chemo to get chemotherapy added to endocrine therapy versus endocrine alone. Here's the results of the RxPonder trial. No statistically significant benefit from the addition of chemo in the population as a whole in this recurrence score of 25 or less. And then because of the data that had been seen in the Taylor-X trial, a look at the premenopausal versus postmenopausal populations was done, so a subset analysis. In the postmenopausal group, there was still no benefit from chemo, but in the premenopausal group, there was a benefit from the addition of chemotherapy of about 4 to 5%. And so for the postmenopausal population, ER positive, HER2 negative, 1 to 3 positive nodes, a recurrence score of 0 to 25, we can likely safely forego adjuvant chemotherapy without compromising invasive disease-free survival. But for the premenopausal, 1 to 3 positive nodes, recurrence score 0 to 25, there's likely a benefit from chemo. The question again, is it chemo itself or ovarian suppression? And is there maybe a lower risk group still in this setting? So we looked at recurrence score of 0 to 13 versus 14 to 25. In the postmenopausal group, even at the higher recurrence score, under 25, the 14 to 25 group, still no benefit from chemo. But in the premenopausal group, both the recurrence score of 0 to 13 and recurrence score of 14 to 25 did seem to have benefit. Now, we should take as conclusions from this work that approaches not just to endocrine therapy, but also chemotherapy may differ by menopausal status or age. And clearly, we need further research to determine if the chemo benefit at lower recurrence scores in premenopausal women compared to postmenopausal women is due to the chemo itself or ovarian suppression caused by the chemo. Further research clearly needed to answer this question. How has the NCCN incorporated this information? Here's the postmenopausal piece of their guideline, and basically it says as long as the tumor is at least ½ centimeter, if there are 0 to 3 positive nodes, you should strongly consider the 21 gene recurrence score to make decisions about chemo. And it also says other multi-gene assays could be considered to assess the risk of recurrence, but they're not validated from a prediction of response to chemotherapy standpoint. Now, the premenopausal is broken up into a node negative and a node positive recommendation. Again, as long as the tumor is at least ½ centimeter, if it's node negative, you should strongly consider the 21 gene recurrence score, but they use different cut points of the recurrence score in order to make statements about whether or not you should get chemotherapy or consider chemotherapy or avoid chemo. So what they say is we should consider the use of adjuvant chemo in women 50 or less with a recurrence score of 16 to 25, but you don't need to give chemo. It should be considered, and if the recurrence score is 26 or higher, you should add chemo. Here's the premenopausal node positive, and here it says if you have lymph node involvement, then if a candidate for chemo, you could consider a gene expression assay to assess prognosis and use the prognosis that comes out of that, but not necessarily the prediction in order to make recommendations for chemo. And you still have a choice of endocrine therapy alone with ovarian suppression or chemo with endocrine therapy in that setting. So multi-gene assays may be helpful in determining benefit of chemo in the 1 to 3 node positive premenopausal group, but it's not as clear. This is a trial looking at the UK experience at using the 21 gene recurrence score on chemo use. They took all of their, or a large group of their newly diagnosed breast cancer patients, ER positive, HER2 negative, with up to 3 positive lymph nodes. After surgery, they used both the PREDICT model to calculate overall survival and benefit from chemo, and a multidisciplinary team had to have reviewed the case and recommended chemo. They then ran the 21 gene recurrence score, and by using recurrence score data, it allowed almost 2/3 of the patients to avoid or have a recommendation against adjuvant chemo. In the node-negative population, the recurrence score resulted in 60% potentially avoiding chemo, and in the node-positive situation, almost 70% have a recommendation converted to avoiding chemo. So the point here is, yes, these assays cost a lot of money, they're complicated, but they can result in a significant proportion of patients avoiding chemotherapy and all of the morbidity and cost of that. So when can we forego a multi-gene panel, even if we're in a high resource setting and we have ready access to multi-gene panels in early breast cancer? Well, we shouldn't run it if there's HER2 positivity or if the tumor's triple negative. If there's a small size like a T1A, we don't have data. These are very good risk tumors. We don't have data for benefit of the multi-gene panel. If there are 4 or more lymph nodes, we don't have data that shows who we can forego chemotherapy in with multi-gene panels. And then in patients in whom the information isn't going to change your recommendation. So a frail patient where their age, health, or comorbidities would preclude chemo, if you're not going to give chemo, don't run the assay. Patients who outright say there's nothing you can do that will convince me to get chemo, don't run the assay. Small, low-grade, strongly ERP or positive breast cancer, you're not likely to get an intermediate or high score. We can avoid running the assay. And large, high-grade, and really low ERPR expression, you know you're going to probably not change your mind with the recurrence score about giving chemotherapy, so you can avoid sending the assay. What should we do when we can't do multi-gene panel testing? There are lots of factors that impact the utility of multi-gene assay, especially in limited resource settings. First is the cost, there's the resource availability. Also, patients present at a younger age, and I think that the use of these assays is a bit less clear in younger premenopausal patients. And in lower resource settings, we generally see higher stage of presentation, and these multi-gene assays were not designed to pick out higher stage patients who didn't need chemo. So if we don't have access to multi-gene testing, we can use conventional clinical and pathologic factors, such as our standard TNM, tumor size, number of lymph nodes. I think the degree of estrogen and progesterone receptor staining can really play a role into how likely do we think that endocrine therapy alone is going to be a benefit. Tumor grade, and in some settings, Ki67, when done well and reproducibly, can factor into whether or not we're going to recommend chemo. And I just cite this nice piece on predicting oncotype DX scores using clinical pathologic features using our U.S. National Cancer Database, which gives information on how to use all of these factors in place of multi-gene testing. We also can use risk assessment models such as the UK National Health Services PREDICT model, and a few non-commercial assays have been proposed. So this is the National Health Services PREDICT model. You put in features of the patient, features of the tumor, and then the various treatment options that you would consider, and it comes back with what would be the expected overall survival with surgery only. If you add hormone therapy, chemotherapy, a bisphosphonate, it tells you if death from breast cancer were excluded, what would be the expected survival at 10 years, and what would be the expected deaths just due to other causes based on the patient's age. This PREDICT model is endorsed by AJCC Edition 8, might be something that you would want to look into if you're not already using it. There have also been a couple of non-commercial assays developed from the ATTACK trial data, the anastrozole versus tamoxifen trial in the adjuvant setting. The IHC4 assay, which has been published, compared favorably in this paper to a 21-gene recurrence score for prognosis. It uses quantitative measures of ERPR, Ki67, and HER2 performed in a high-quality laboratory, comes up with a complicated algorithm here where you give different weight to the different quantitative measures of these factors, and it compared favorably to the 21 gene recurrence score. The CTS5 is the clinical treatment score post 5 years of endocrine therapy, also derived out of the ATAC trial, and it estimates residual risk of distant recurrence after 5 years. It's validated for patients 50 or greater, and it just includes the number of nodes, the size, the age, and the grade. And there's an online calculator you can use for this. This is more helpful in looking at extending the duration of endocrine therapy rather than selecting chemotherapy, but thought I'd show you this nice calculator. So in conclusion, who needs chemotherapy in hormone receptor positive early stage breast cancer? Well, we know that both disease burden as well as tumor biology matter, and Ajcc edition 8 has created a prognostic stage versus the classic anatomic stage to delineate that. We know that approaches to both endocrine therapy and I've shown you now chemotherapy should differ by menopausal status. We know that there are some conventional clinical and pathologic factors and risk assessment models that can be used in defining prognosis and are frequently used in making decisions about adding chemo. We've also seen that multi-gene assays can provide predictive information for chemotherapy benefit and lack of benefit in select settings, and this definitely can lead to decreased chemo use. And the take-home message here is that not all early-stage breast cancer patients need chemotherapy. Thanks for your attention, and I'd be happy to take questions during the question and answer period. Thank you very much.
Thank you very much, Professor Garalo, for this very nice and very important presentation. And now the floor is open for questions. Dr. Muhammad Sabri.
Thanks for your elegant presentation. Dear Professor, I want to ask you about in the last 2 years in the COVID era, many patients, elderly patients with nodal positive disease are put in the waiting list for more than 6 months for hormonal treatment till achieving a radical surgery, either lumpectomy or mastectomy. And a lot of them coming back after surgery with patients, specifically with patients with nodal positive disease, post neoadjuvant hormonal treatment, asking us if it's worthy to go for Oncotype DX for me to avoid chemotherapy, or I should, depends on the clinical data that the patient is not responded well to hormonal treatment, and I can go for chemotherapy without costing the patients the cost of Oncotype DX for non-responders for neoadjuvant hormonal treatment.
I think that's a great question, and a lot of us have moved during the COVID era, especially during the peaks, to giving neoadjuvant endocrine therapy to delay surgery because we didn't have room in our operating rooms in our hospitals to take the patients to surgery. You know, we have some pretty good data in HER2 positive and triple negative breast cancer that neoadjuvant chemo and the response to that can predict outcomes, and we have strategies where we can reduce post-operative adjuvant treatment based on response to preoperative chemo and HER2 therapies. What's interesting is, while we absolutely see responses to preoperative endocrine therapy, those responses take a lot longer to happen in general. You know, the most ER-sensitive cancers are not fast growing. And so we don't quite have the same strength of data using response to neoadjuvant endocrine therapy to definitively say you don't need chemo or you do need chemo. We have lots of trials going on in this area. I think it can potentially move to be a predictor. If you had an excellent response to preoperative endocrine therapy after 6 months, especially if you had a complete response, which is very, very rare with endocrine therapy. Those responses just don't happen quickly. Could it be used to say no chemo, and then that would be another predictor, another model? I think we need a bit more data before we have really definitive proof, but I think it's a very promising area. I think it's a great question, and I think it was really, in some ways, the COVID pandemic that kind of pushed us to give a lot more preoperative endocrine therapy and to learn more about this. So it's a great question, a hot topic, and we may ultimately have really strong data that tells us this is one way to predict if you need chemo or not.
Thank you very much.
I have
Dr.
just
Raulo.
one question. Regarding patient with luminal HER2 negative tumors, when to give short course radiation chemotherapy versus long course chemotherapy, anthracycline taxanes versus, for example, taxane and cyclophosphamide alone for 4 cycles.
Great question. We don't know really who needs an anthracycline, who needs 6 cycles versus 4 cycles. I mean, if we're sticking strictly to the evidence of the trials, you know, it's tough. When I will just tell you that this is where medicine is more of an art and less of a science. You know, we have all been in practice. We would guess that an older patient who might not tolerate the anthracycline as well, might not tolerate the chemo as well, and also has a lower risk cancer, I'm going to get 4 cycles of TC, for example. A young woman where, you know, we're going to do everything we can to give her the best chance of being alive, to raise her family and get them through school and all. I'm going to be more aggressive, just in general. That's where the art as opposed to the science comes in, because I don't think any of these predictors have told us who needs an anthracycline, who needs longer treatment. I think we're doing a lot of studies looking at de-escalation of treatment. And I've been in practice long enough to remember back when we had a National Cancer Institute consensus conference on adjuvant treatment of breast cancer, you know, way back in the 1990s. And we said every patient with early stage breast cancer should get chemo because we can't figure out who doesn't need it. And clearly, as soon as we made that statement, we knew we were wrong, and we started a whole body of research to determine who needed less. And that's where we have to go. So not solid data telling us who to give more, but increasing data to tell us who we can omit it in entirely, and especially in that premenopausal population where we're not sure if it's the ovarian suppression versus the chemo that's adding benefit at some of the lower recurrence scores. We really have to work on, okay, if we decide we're going to give chemo, could it just, you know, could we give ovarian suppression instead, or could we give lower dose chemo? So I didn't really answer your question on exactly what the right thing to do is, but I think that's where we use some judgment because of lack of evidence, and that's why we need to focus research there.
Thank you very much, Dr. Jolly Grow. And unfortunately, we have to end our session because of the time. And I hope to meet you physically maybe next year, inshallah. Also, I want to thank all the distinguished speakers that were with us, Professor Gratier, Professor Sara Tolani, Professor Tamer Rifat, and of course, I thank all our chairman, Professor Hiba El-Zawahri, Professor Midhat Sebai, Professor Amani Hilal, our guest, Professor Lubna, and also my colleagues, Professor Hani Abdulaziz and Professor Muhammad Sabri. And now it's ended our press session, and for the following one, thank you very much.